Very nice.
All right. Bonnie, we good?
We are.
Then good morning, everyone. I'd like to call order this regular meeting of the Board of Retirement. It is exactly 9 o'clock on Wednesday, October 27th, and this is the second day of our board offsite. Bonnie has some announcements and we'll do the roll call.
Thank you, Chair Bernstein. This meeting is being held virtually, so I will do a roll call of the trustees to confirm attendance. Mr. Pryor? Mr. Knox is joining us now. Ms. Ginsburg?
Good morning, present.
Good morning. Ms. Gray?
Good morning, present.
Mr. Santos? Mr. Oakham?
Morning.
Morning. Mr. Moore?
I'm here.
Thank you. Mr. Kehoe?
Good morning, everyone.
Good morning. Mr. Robbins?
I am present.
Mr. Harris?
I'm here.
Thank you, Mr. Fanta. And Chair Bernstein.
I am here.
Thank you. Staff participating in the meeting includes CEO Santos Kryman, Deputy CEO Louis Lugo, CIO John Grable, Assistant Executive Officers JJ Popowich and Laura Guglielmo, Chief Counsel Stephen Rice, Staff Counsel Frank Boyd, Dr. Glenn Erisman, LACERA's Medical Advisor. We have Stephen Murphy, Michael Cizzetto, Richard Ward, Paul Sadro, Stephanie Messier, and Jessica Coleman from Siegel, Kathy Bakek and Amy Dunn from Siegel's National Healthcare Compliance Office is also joining us, and RHC Director Cassandra Smith. You have a comment or question, use the Zoom raise your hand feature to be acknowledged, and now we may proceed with the agenda.
Great.
My name's just Keith. I'm here. Sorry.
Thank you.
Welcome. Anyone else arrived during the announcements to check in? Bonnie, do you want to just quickly go through the people you didn't get before to see if anyone's shown up?
Yes, I don't see the following individuals in our platform for attendance: Mr. Pryor, Mr. Santos, and Ms. Sabanta.
Okay, well, hopefully they'll be arriving shortly. Bonnie did say, but a reminder, we're going to try to keep the tenor of today relatively informal. I'm going to try to not need to call on people. So as we're being addressed and spoken to, please feel free to use the raise hand feature or comment in the chat so you can jump in. Presenters, please don't wait for me to acknowledge people. If you're presenting and someone has a hand up, please feel free to acknowledge them. I thought that worked very well yesterday, and I trust it will continue to work well today. And with that, I would like to have welcome and opening remarks from our CEO, Santos Kryman.
Yes, thank you, Chair Bernstein.
Excuse me, before we begin the proceedings, could we confirm the absence of public comment?
Thank you so much. I'm happy, Mr. Rice, to confirm that we did not receive requests from the public to speak, but the opportunity was available if anyone had wanted to execute it.
Thank you.
Okay. Thank you, Chair Bernstein, Vice Chair Gray, trustees. Welcome to day 2. We have quite a number of items that we're going to go through. A lot of it is educational based. I'm really looking forward, actually, myself personally, to Medicare 101 to get a better handle on things that are going on in the Medicare world. Everything here is important for us to go through and to understand. I'm going to go ahead and turn it over to Mr. Lugo so he can go through the agenda for us. I know that we have a short day today. Thank you for those of you that were in attendance yesterday. I know it was a long day, and so we're going to try to get through this material as quickly as we possibly can, but allow for enough time to make sure that we answer all of your questions. And so with that, Mr. Lugo, do you want to walk us through the agenda?
Yes, thank you, Santos. Good morning, Chair Bernstein, Vice Chair Gray, and trustees. Today, as Santos mentioned, is really going to be educational and informative in nature. We're going to focus on kind of our healthcare landscape as it relates to Medicare, really important information for our members and employees alike, as well as some information at a higher level in terms of the healthcare landscape around compliance and legislative that we'll get from Siegel later in the morning. But for today, for this morning, to kick us off, as we discussed during some of the presentations yesterday, COVID-19 has certainly played a significant role in the way LACERA conducts our business. It's also had a personal effect on our members and employees alike, both mentally and physically. We'll now hear from LACERA's medical advisor, Dr. Esserman, on the long-term consequences of COVID-19. Dr. Esserman, you can take it away.
Okay, let me put my screen up here. Okay, I should be unmuted, but I don't see my slides popping up here. Let me see. Just take a minute to do this, I guess. Let's see.
So Dr. Glenn, we do have your slides available, so you can just go ahead and begin your presentation and let the facilitator know when to go to the next slide.
Oh, okay. So we'll just do it that way. Perfect. So if we can have the first slide up, then that would be great. There it is. Okay. So I think the comment that was just made is very important for all of us to think about, because COVID has touched probably everybody at this conference, and as well as many of my colleagues and myself and my family. So it's had a major impact on most of us in either a direct way because of our own family or friends or colleagues being ill or passing, and also indirectly because every day of our life there are issues and concerns that come up with respect to the consequences now of COVID infection. And I have to tell you, it's just not over yet, okay? It is not over at all. On my way here this morning, I had a patient who is 88 years of age and has been scrupulously careful about being isolated. She's had double vaccination, even though she's a Christian Scientist and doesn't really want to do those things. And she's just done everything right. Well, last Saturday night, she had family over, and a youngster, 13 years old, amongst the group that was there, has come down with COVID as of Monday morning. So she's had an exposure, and we're still dealing with that. So it's still an active problem. We're still not through this pandemic. That's absolutely for sure. But this morning, what I wanted to really speak with people about was the consequences of the COVID-19 infection. We're obviously aware of the severity of this disease when people can go from relatively minor symptoms to being on a respirator within 24 hours. And I dealt with this in a family way with my son-in-law, perfectly healthy 45-year-old man who had COVID. He actually acquired it from my daughter, who's a physician, who acquired it in her office, along with 2 other staff members. And my son-in-law was having what seemed like a modest COVID course until about 7 days in to the course, when he suddenly became tachypnic, and he suddenly went from 12 hours, was slightly short of breath, to desperately short of breath. Within another 12 hours was on a respirator in an intensive care unit for over 7 days before he recovered. All right, he was sent home from the hospital in a wheelchair on oxygen because we had no space. We needed patients out of the hospital. And that was back in December. So just to give you a little flavor from a personal experience of how devastating this can be, a perfectly healthy man reduced to being dependent in a wheelchair after recovering, quote unquote, from this infection. He was sent home assisted in every function. He could not get out of bed independently, could not feed himself independently, could not even sit up independently. And here is a man who was working full-time at the county hospital in interventional radiology before all of this happened. And so not surprisingly, it did take him some time to recover. And I think we consider him one of the lucky ones that he did recover, and he is now back at work. But that return to work took 7 months, okay, after this acute infection. And that's, I think, the flavor of what I want to speak with people about this morning, that while the acute consequences, the morbidity, the mortality have affected many of us, and we're very familiar with that, the consequences over the more long term are a little bit less well understood. And we now have the situation of patients who survived COVID who have residual problems that are important for us to be able to deal with. Let's see, the next slide then. So what do we, first of all, label these people? Some people have called them long COVID, and another term that seems to have become most popular, the handle of COVID long haulers. It's really kind of an umbrella term. It really is meant to describe those symptoms and consequences mentally, physically from the acute infection that persist for weeks after the infection is resolved and there's no evidence of the virus remaining in the system. And sometimes these kinds of symptoms happen not just in people who are desperately ill, like my son-in-law, but people who had rather milder symptoms. And there are occasional patients who have been cultured positive for the COVID virus who have no acute symptoms, but seem over time to go on to have some of the more chronic symptoms that we'll be talking about. So there really is a spectrum here. And obviously in the people that had severe disease, respirator dependent, who lost immense amount of muscle during an acute hospital stay, we would expect them to require weeks, if not months, to recover. But it turns out that even people who had milder infections who were not hospitalized may have some long-term consequences that are physical. So I think that this is something that was not as well recognized, and I think there's some people in the media that have perhaps made this a bit more evident to us. One, Dr. Drew Pinsky, who was not hospitalized, but who has had some long-term consequences, and recognizing then that this does affect people physically for longer periods of time. Mentally, it's a very interesting consequence. I recently saw a patient who has terrible survivor guilt. She was vaccinated. Her mother, her sister, and her brother were in another country unable to get vaccinated. All three of them died within 1 month from acute COVID infection. And she was feeling great regret and great guilt because she was not able to get them to be vaccinated. So there is a bit of survivor's guilt in this person who didn't even have COVID, but people who have had COVID, who have survived COVID-19 infections, are sometimes left with the burden of guilt when they've lost people close to them. My son-in-law, again, one of his closest colleagues, came down with COVID a short time before he did and died after 5 days. And he has remorse for that. And it's a burden that is not so easy to explain, because clearly he had nothing to do with her coming down with COVID, but he has great anxiety and sadness and almost guilt about that. And that's one of the things that's also been prominent in people who have survived COVID and they didn't pass away and others close to them did. My son-in-law lived through 2 people dying next to him in the beds next to him during his hospital stay. One attempted resuscitation, and the other was in do not resuscitate. And it made him wonder, am I going to be resuscitated if I have a cardiac arrest? He was still intubated. He didn't know if he was a DNR, as they call it, do not resuscitate, or whether he was a full code resuscitation. Next slide. So what are some of the symptoms? Well, some of these things we would typically expect. Shortness of breath, the lungs are damaged, and sometimes after people recover from COVID, they will have persistent impairment of their pulmonary function for a very long time. We don't know how long that may be. We know of patients that have been hospitalized with COVID whose acute infection is gone. There's no evidence of any persistent virus, but they're still dependent on respirator support because their lung damage was so severe when the infection was present. And some of these patients may be potential candidates for lung transplant even, but that's not something that's very likely to happen in the short term until the patient makes a complete recovery in other ways, because they're not considered a good candidate. There's cognitive dysfunction associated with COVID infection. And again, this may happen in patients who have not had severe enough infection to be in the hospital. While we all have compassion and concern and understanding for people who were, like my son-in-law, on a respirator for 7 or more days, it's not always so easy to understand the symptoms that some other people have had who've had a significant infection, but not to the point of being hospitalized, intubated on respirator support and so forth. But let me share with you that I have several patients who had very significant COVID infections with a typical course of myalgias and fever and some cough, but not to the point of being in the hospital. After their recovery, they look fine, they walk fine, they do everything fine, but they tell me, you know what, I just can't handle multitasking the way that I used to. I can't get my brain to wrap around certain things. I can't look at Excel spreadsheets. These are things that I've heard from people who've had COVID. And I believe it, that there is a consequence that has been disruptive for people in terms of their alertness, their attention to task, their ability to persist in an activity, and their ability to handle the amounts of data and things that they used to do without difficulty. So that's one area that still needs to be elucidated in terms of understanding how much deficits people have. And there's some psychometric studies that are being done on patients who've had COVID to try and quantitate that. The problem is you don't have something to compare it with before in most cases, because these were healthy people without known cognitive dysfunction. So making an assessment of the delta from what they did before to what they can do now is sometimes difficult. Fatigue, I think, is uniformly present in people post-COVID, and that the activities that used to be very simple, like taking a shower, getting ready for a meal, are activities that just seem at times overwhelming to people who have had significant COVID infections. And so this is something that, again, tends to improve over time, but in some people it persists for longer periods than others. And when people look fine, it doesn't mean they are fine. And I know of patients who normally walk their dog for 3 miles a day that months after COVID cannot do that. They're walking their dog maybe 1 mile a day, but they're not back to their 3 mile a day walk as they were before. So it's a very subtle but persistent deficit that is attributed to the prior COVID infection. Now, you see a bunch of other things that are listed, and they say there's up to 200 symptoms that have been reported. And I've seen patients, certainly, as I said, with anxiety, with depression, guilt, the survivor's guilt type syndrome, I think is really more frequent with this condition than I've seen in other situations. Long-term aches and pains, the persistence of loss of smell and taste in some patients is very long-standing. Occasionally, people will have persistent chest pain. Usually, it's more muscular type pain, muscles associated with respiration. Sometimes it's a bit what we call restrictive disease of the chest, where the lungs have some fibrosis and do not respond the way that they did before. And some people will have need for persistent use of oxygen. So one of the problems comes in terms of evaluating patients' symptoms after COVID is to try and ascertain whether those symptoms are related to the COVID infection and consequences, or is it some other syndrome? Let's go with the next slide, please. So here are some of the things in terms of body systems on the left that have been associated with COVID infection and post-COVID. So cardiovascular, many of you have seen reports about myocarditis. There are even some reports about myocarditis, inflammation of the heart developing after vaccination. But certainly from the virus itself, there have been people who've had myocardial involvement, not a heart attack, but inflammation of the heart muscle, resulting in heart failure, sometimes fluid around the heart, inflammation inflammation of the pericardium. And sometimes people have had difficulties with their blood pressure after COVID. And this is not an uncommon situation that we associate with deconditioning, where people have been in a hospital, in an ICU, or just ill and recumbent for a period of time. And when they go to get up, their blood pressure drops and they have fainting symptoms, and their pulse rate will go high. And these are things that can persist for some weeks to months afterwards. Pulmonary interstitial lung disease, which is scarring basically of the lungs. What we call reactive airway disease, where the tissues in the bronchial tubes react to cold, for instance, and constrict the bronchial tubes, react to, like an allergy patient would react to certain environmental stimuli. Kidneys can be involved. You can have some degree of kidney damage from the acute infection with a drop in blood pressure, and there can be some longer term consequences. Dermatologic, there are things such as COVID toes that have been described that have a peculiar appearance, but people have lost their hair, either in patches or diffusely after COVID infection. And you see under rheumatology, which is what I do, reactive arthritis is not uncommon. That's a condition where joints become inflamed, and we believe it's a reaction the person's immune system had to what their infection was, in this case, COVID. Other people have had the onset of fibromyalgia symptoms, which you've heard about before, a widespread pain disorder that's associated with sleep difficulties and may be temporary. And there's historical cases of this back in the 30s at LA County Hospital. There was an epidemic of a viral condition which left people with a fibromyalgia-like condition afterwards. Connective tissue diseases are listed here as a group because people have come down with lupus, with rheumatoid arthritis and scleroderma, not caused by COVID, but perhaps triggered by COVID, which set off their immune system. Endocrine, certainly diabetes and hypothyroidism are things we have to check for in people who have post-COVID symptoms, and they may show up for the first time at that point. Neurologic symptoms, we kind of talked about the degree of weakness and the fact that the loss of smell and taste may be very persistent, the cognitive changes that I talked about, and also there may be an immune-mediated neuropathy that is present in some patients. So virtually no system is spared. And then psychiatric, we've touched on already. Hematologic, there is a tendency for people with COVID to have an increase for blood clots. We know very well about that during the acute infection. Pulmonary emboli can complicate the situation, but we don't know how long that risk for increased thrombosis actually persists. And it may be that it's months afterwards. Urologic problems in the very sick patients are understandable. They had catheters, they may have infections. They may, however, have some persistent neurogenic problems after their COVID infection. And so, the things that we commonly think of in terms of loss of muscle mass, the weight loss, these are things that are very persistent for some patients. And you see that there have been cases of acute hearing loss associated with this. And even actually, I know of 1 or 2 cases that have happened after vaccination. So the immune consequences of the viral infection go way beyond the time of the infection itself. Next slide. So how long is it going to last? Well, we know that it lasts 3 to 6 months in many patients and up to 9 months in some patients. As I said, my son-in-law was able to get back to work after 7 months, but at a somewhat less intense schedule than he did before. And I'd say a full 9 months, and he's now pretty much recovered. So we're still kind of figuring this out because we don't know how long this is going to last. And some of these neuropathic conditions, nerve-based or neurologic-based conditions, may last for longer periods of time. Not all nerves regenerate, not all nerves regenerate quickly. We know that nerves grow maybe 1 millimeter a day. So that's, if a patient has peripheral neuropathy, can take a very long time. Next one. So what about lab testing? Is there any way to test if a patient has severe fatigue after COVID infection, that this is related to COVID? Well, unfortunately, there are no tests that will tell us whether a particular symptom is related to the COVID infection. So what we basically do is we look at patients who had COVID infections to look for other causes of symptoms like neuropathy, fatigue, musculoskeletal symptoms. And sometimes we'll find those kinds of causes, like the new onset of a disease like rheumatoid arthritis, the new onset of a disease like multiple sclerosis, which again, probably we would not consider this caused by COVID, but perhaps precipitated by the stress of a COVID infection. We know that certain diseases like lupus, like rheumatoid arthritis, tend to come after certain physiologic and sometimes emotional stressors. And so it's not surprising that a COVID infection could be associated with those kinds of circumstances. And so what we generally want to do is, in a person who has persistent symptoms that we think may be COVID related, look at basic lab testing, CBC, be sure there's no anemia, chemistry panel to be sure the potassium is okay, the muscle enzymes are okay, the liver tests are okay in the first few weeks after the COVID infection. And then do perhaps more advanced testing if there are any red flags that come up with those things, and look for evidence of inflammation. We look at the sedimentation rate, we look at the C-reactive protein. Those are two simple measures of inflammation. If they're there, then we need to look for additional things. And then consider more advanced testing if symptoms persist for more than 3 months. Next slide. What are the basic laboratory tests? And I pretty much listed what I just spoke of there. So the basic ones would be the CBC on the top panel, the liver test, the inflammation markers, the thyroid function, and also very important to look for vitamin deficiencies. And the two that are most prevalent probably are vitamin D being the most prevalent, which you would be surprised that in California, there are many people who are vitamin D deficient. We don't, as adults, drink much milk, which is fortified with vitamin D, and we're careful about the sun more than we used to be. And so it's not surprising that we see some degree of vitamin D deficiency. Vitamin D of all the vitamins is probably the most important with respect to the musculoskeletal and the immune system. It's well known that patients who are deficient in vitamin D have less robust immune responses than those who are replenished with vitamin D. Vitamin B12 is a little harder to become deficient in, but it's a very important one for nerves, so it's very important to check that one. Low vitamin B12 is associated with severe nerve damage, and regrettably, that is not likely to get better just replacing the vitamin D if the primary reason for the nerve damage is vitamin D deficiency. So if a person has vitamin B12 deficiency on top of a neurologic consequence of COVID, it's especially important to replace that vitamin B12. And then the specialized tests looking at things like the rheumatoid factor test, the coagulation test, the myocardial test for injury of the heart would be a troponin test, and then trying to look through other tests to decide if a patient has a cardiac consequence of the disease or a musculoskeletal consequence. Next slide. Okay, so for most of our patients, really, the goal of medical management is just what it says, to optimize function and quality of life. I think number one is to recognize that there are long-term consequences of COVID, that patients should not feel guilty because they continue to have fatigue, because they can't do the same things that they did as efficiently as they did them before. We don't want people to be suffering under a double burden of the consequence of their illness and the feeling of guilt for not getting back to being normal again. Okay, and recognize that, you know, there will be some patients who need a completely comprehensive rehab program. For some patients, some needs to focus on more cognitive skills, some needs to focus just on simple things like walking and exercise, endurance training, and physically building up weaker muscles and so forth. Contractures are very problematic for people who've been in the hospital for a while, where they have stiff shoulders from lying in one position, and they need to have somebody work with them to improve those areas that are challenged from the residual limitations related to COVID. And I think the other thing is to be, my talk today has kind of been a bit negative in terms of all the things that can happen from COVID infection, but to be optimistic that there will be improvement for most patients. There are certain things that may be persistent, like the loss of hearing, for instance, may be something that does not recover. But most of the other things that we've talked about can recover, and if not back to completely normal, to a new normal that allows the person to do most of the things in life that they will want and need to be able to do. So I think that, we're still learning, and I think we'll have more information in another 6 months about these post-COVID syndromes, or the long haulers, and what to expect and what we should be focusing on for the future. And that's pretty much it. I think that's the last slide, right, Bonnie? Oh, yeah, one more. So treatment. There isn't a specific treatment. None of the things that I have talked about will just go away with vitamin supplementation. But vitamin supplementation, especially vitamin D and vitamin B12, if indicated, is very important for those people that have deficiencies in those situations. There's been some data that suggests that vaccination post-COVID infection seems to help people recover a little more quickly. That's not totally scientifically validated. I mentioned the need for therapies, physical, occupational, speech therapy, and sometimes counseling would be important. And then recognize that prior comorbidities or new comorbidities from these conditions that develop post-COVID will be problematic for people as they recover from the post-COVID syndrome. And that's the last slide. Okay, thank you all very much. Appreciate it.
Thank you, Dr. Erisman. If there's any questions from trustees, I know we're scheduled to break at 10:15, but I think we're going to continue to go to the next presentation, Medicare Basics. But before we introduce our next presenters, is there any questions for Dr. Erisman? Dr. Erisman, I do have just a question. In terms of the COVID long haulers, and I know the information is fluid, but what's the percentage of those that test positive for COVID actually that actually have those symptoms, those long hauler symptoms?
It's being recognized more than it was initially, but somewhere between 10 to 30% of people who have COVID have some degree of long haul symptoms. That doesn't mean 30% of people are disabled and not returning to work, but they may have symptoms that do persist. Okay, thank you all very much.
Thank you.
Ms. Gray has a question.
Yes, Dr. Erisman, very quickly. As you know, we, as trustees, review the disability applications, and you are our advisor. How do we deal with the COVID long haulers if specifically we have a member who applies for a service-connected disability with those issues that are that happen because of COVID, like the rheumatoid arthritis or nerve damage or the other issues that have been outlined? Is it necessary for their physician to say, this person is totally, this person can't work anymore because they have X condition? Do they have to say it's as a result of COVID?
Now that's a difficult area. You're identifying the question that nobody wants to, give a definitive answer to. I think that for certain kinds of diseases, for instance, rheumatoid arthritis is not caused by COVID, but the link is there that it developed following the stress of a COVID infection. And so it was a precipitating event. Now, is that if that person acquired COVID at work, then is that considered a service-connected link? And I don't think that at this point, there's enough data to support that a disease like rheumatoid arthritis would be considered a service-connected disorder, okay, from the information that we have. There would have very likely been other events in that person's life that could have been equally likely to precipitate rheumatoid arthritis at some point. But the issue that's the important part of the question, I think, also is the degree of long haul symptoms and the duration of long haul symptoms and how incapacitating there are. And there may be some people who, will be incapacitated, and it could be considered service connected, certainly if they got COVID at work. And let's say they lost hearing because of the COVID direct consequence on the ear, and that doesn't improve, then that would be a very discrete, concrete one. The problem is going to be those ones that are less specific: fatigue, concentration difficulties, functional impairments for things that people did easily before but have just a more difficult time doing those. And that's where we're going to have to rely on the attending physician and perhaps some of our panel consultants to quantitate and verify the degree of these symptoms and the duration of these symptoms to decide if they're really permanent or not. And I think the one thing that I would suggest is we would not want to make decisions too early, because everything suggests that people do improve over time. And there are clearly some who have consequences. Let's say, for instance, a patient whose COVID is gone, but they can't get off a respirator because their lung damage is so bad from the consequence of the infection with fibrosis. So there's somebody who's not going to get better, okay? And that's a consequence of the acute infection, and it's very clear there that infection was the cause of that pulmonary decompensation and scarring and so forth. And that's one that will be straightforward and easy. The ones that are going to be very difficult are the ones that are the more subjective symptoms, where we will perhaps need to do some neuropsychology testing to quantitate, their intellectual function. And the problem there is we won't have something to compare it with, you see. So we're going to have to rely on those kinds of quantitative measures, or semi-quantitative measures, and the reports from attending and panel physicians.
Ms. Gray, if I could respond to your question from a legal perspective, if the evidence were to show that the member contracted COVID at work, and the medical evidence shows that the COVID had some contribution to whatever physical incapacity the member has, you would treat it kind of the same way we look at aggravation, acceleration, or lighting up legally. So that's how we look at it if it came to us.
Okay.
Thank you.
In which case then a chronic illness that appeared as a consequence of COVID infection potentially could be considered service connected. Is that right, Frank?
Correct.
Okay. All right.
All right. Thank you very much.
Thank you.
Thank you, Dr. Erisman. Thank you, Vivian, and thank you, Frank, for that clarification as well. We're going to switch gears now. Medicare continues to serve as a point of confusion for our active members and retirees, whether it's understanding the enrollment process, eligibility, or as I like to call it, the various alphabet offerings, A, B, C, and D. As Cassandra highlighted in her presentation yesterday, the Retiree Healthcare Division is committed to producing quality educational and instructional content to better assist our members. We're pleased to have Stephen Murphy, I should say, with Siegel, our retiree healthcare consultant, and Cassandra Smith, our director of retiree healthcare, to present on Medicare basics. Stephen and Cassandra, the floor is yours.
Yes.
Good morning.
Good morning.
So, yeah, Cassandra and I typically are joined at the hip, so I understand the confusion. So I think your overview, encapsulated this perfectly. Medicare was begun 56 years ago, and it is nothing comparable to what we're used to seeing today as a benefit program. So it's very clear that it's confusing for anyone that's entering the system or trying to take advantage of the benefits available. So our intent this morning is to walk you through, give you an introduction of Medicare and some history, go over some of the various components. But as we go through this presentation, we're going to break it up into a couple pieces. One, as we go through the information, we'll also try to highlight areas where LACERA kind of integrates well, or there may be opportunities where there's some friction. And so again, that's where I think the retiree healthcare staff steps in and plays a vital role in educating retirees and those contemplating retirement in terms of how to take advantage of the benefits available to them. We'll also do a little bit of testing or polling to kind of see if we're tracking and everybody's kind of absorbing the information. So hopefully that'll be the fun part. But again, I think we look forward to your questions as we go through this, because again, it's really vital and important to understand this foundational element to LACERA's overall retiree healthcare program. So we can go to the next slide. And one more. So as I'd mentioned, there are more than 60 million people covered under Medicare, and AARP estimates that number will be 79 million by 2030. The program was created in 1965 during the Johnson administration and was originally designed as a safety net to ensure that Social Security beneficiaries age 65 and older would have health care. In 1965, Medicare did not cover anyone that was not 65 years or older. In terms of some adjustments, originally Medicare was designed to align with the original Social Security retirement age of 65. And in 1972, during the Nixon administration, Medicare was expanded to cover individuals under age 65. The first category was disabled individuals that had been disabled for at least 24 months and receiving Social Security benefits. And the next category was those receiving treatment for end-stage renal disease. And we can go to the next slide. Again, originally designed in 65, Medicare had two parts: Part A, which covers inpatient care or hospitalizations, and Part B, which covers outpatient care, physician visits, lab tests, things of that nature. Original Medicare, and also referred to as traditional Medicare, is provided to reimburse expenses on a fee-for-service basis. And so we'll use the term traditional and original interchangeably throughout the remainder of the presentation. Not too different than what we're experiencing today in Congress. Back in 1965, parts A and B were funded differently through a political compromise. So Part A was funded through federal payroll taxes, or FICA, and Part B is funded through general revenues and beneficiary paid premiums. Next slide. The Balanced Budget Act of 1997 introduced Part C as an alternative to the original Medicare. Part C provides coverage benefits that are similar to Parts A and B, but the delivery is generally on a managed care basis. And so to make that tangible, Medicare Advantage plans like your Kaiser Senior Advantage plan or through United Healthcare or SCAN, those are commonly plans offered through a Part C delivery system. So just for reference there. And then in the Medicare Modernization Act of 2003 expanded Medicare by introducing Part D, which is prescription drug benefit. Part D is delivered through private pharmacy benefit managers, and those are often integrated with the overall health plan. So again, your Kaiser Senior Advantage plan has a pharmacy component built into it. SCAN has a pharmacy benefit built into it. And so, that's how that works.
Steve, can I jump in real quick?
Absolutely.
Just for a reference for our retiree healthcare program, a reminder, we ask members not to enroll on their own in Part D. And that is because, as Steve alluded, the members that enroll into our Kaiser Senior Advantage, our United Health Medicare Advantage, any of our Medicare Advantage plans will automatically get Part D, as in David.
And I think one of the this is a crucial time of the year where individuals are receiving outreach from a variety of organizations trying to draw enrollment. And it's oftentimes in conflict with the programs that they already have through LACERA. So again, this is really a difficult time for retirees and can often become confusing because they could be enrolled in Kaiser Senior Advantage through LACERA, but could also be receiving enrollment solicitations from Kaiser on an individual basis. And so there can be a lot of confusion about, is that my plan, or do I need to take any action?
And this is where we find members during this time because of the open enrollment and all. Members will sign up and inadvertently get signed into another plan outside of LACERA. It may take us 2 to 3 months before we even find out. And during that time, we're still reimbursing or we're still paying our carriers. And because they are disenrolled retroactively, we have to go in and collect those paid premiums as well as the Part B from the member. And a lot of times they're not even aware of what they're doing because they have smart salesmen that are getting commissions, and they will say whatever it takes to get that person enrolled to get that commission, unaware of the confusion and the frustration that they're causing to our members.
Yes, Cassandra,
Yes,
with my clients, we don't get any commission on Part D. Okay, you got to go on the computer and figure out what drugs they're taking. And then we find the best plan for them and they have to do the enrolling. We help them enroll.
right.
Now-
That's you guys. But when they walk into, say, Walmart or Albertsons and they see those individuals, those are the ones that are getting them enrolled.
Okay, I see what you're saying. Now,
Yes.
question. Do the plans well our members?
I'm sorry, you were coming in and out. Can you repeat that?
What can you hear me okay?
Yes, now I do.
Okay, my question is, are they reimbursed, when you got different categories? And do these plans cover most drugs, or do the doctors have to call up and say it's necessary? What kind of situation are you finding with the plans that cover the drugs?
It
They doing-
depends on the various plans. For example, Kaiser does a lot of generic drugs. However, they do issue some brand name drugs, but each plan has their own formulary, which our drug benefit is very lucrative and equally as good as that what's being offered through the Part D plan.
Okay, that's good. All I know is this, is I'm taking one drug that used to cost me about, $8,000. I'm taking the generic now. I just got a report yesterday, and I'll probably spend $2,000 totally on drug costs. So it's gone down from maybe 8,000 or 9,000 a year to 2,000. Are you experiencing the same thing?
We are
with
seeing,
our members? and
yeah,
their
we are
costs?
seeing members that pay, that some only know what their doctor tell them and they don't want to hear anything else about a generic drug. But once we talk to them and tell them, you are aware that this is a high costing drug, and while you may be paying 4,000 of it, if you take this generic drug, it may decrease your cost down to 2,000 or 1,000. It's something to
Right.
look into. And
Okay.
so some of our members are well receptive of that. Some of them say we're not doctors. So
Yeah.
it's a hit and miss.
Yeah.
Ms.
Okay.
Gray,
Thank you.
you're on mute.
Just a quick question. Based on what you've outlined with respect to the various options that our retirees have for their medical coverage, do we recommend, obviously they have to sign up for Part A. That's mandatory under the law once they hit 65 if they're retired, correct?
Okay,
But-
so let me make a correction. If they work 10 years, which equates out to 40 quarters, they will automatically get Part A free. If they pay less than 10 years, then it's like a tiered cost to Part A if they want to purchase it. But we don't ask our members to purchase it if they're not eligible for free A.
Okay, so if you are eligible for Part A, that's free, correct?
Correct. If they've worked 10 years, they're eligible for free Part A.
Okay. Even though we didn't pay into Social Security.
That's the county. That's a little different. See, so like, for example, say I was in the military and I paid Medicare or Social Security through the military. If I stayed in there, say 20 years, I have my 10 years worth to qualify me for free Part A. However, when I came over to the county and started working, The county was not paying into Social Security. So if I only based it on my county employment, I would not be eligible for Medicare.
Well, what I was trying to ask was, so our retirees, do they have to sign up for Medicare at age 65? I'm talking about Part A.
If they're eligible for it free, they'll automatically get it. There's nothing that they'll have to do to get it. It will automatically be sent out to them by Social Security.
Okay, so I had a question on Saturday by some members, and they wanted to know, do they need to sign up for B, C, and D? I told them to call you. I am, you know what, after 10 years of being on the board, I ask this question every year, Cassandra. I am totally, as my granddaughter says, I'm fused.
It can be tricky, and we always advise members, if they're eligible or they're entitled to it, they should take it. Our advice is take it. And if you see, once you see how it works for you, you can keep it. If you don't like it, then you've tried it and you won't get that penalty, which you'll hear about further into our presentation.
Okay.
And Trustee Moore, I know you have a question, but just a point of clarification for Trustee Gray. So Cassandra, in terms of the FICA tax, and I know the county doesn't pay the 6.2% Social Security, but they do pay the 1.45. When did that come into effect? Because I think that also plays into whether or not individuals have that 10 years of coverage. So can you kind of go over that timeline?
Good question, Louis. Yes, the county discontinued paying Social Security in 1982. In 1986, April of 1986, the county began mandating participation paying HIT tax, HIT, which is health insurance tax. Our employees that are working that pay our work for 10 years will then qualify for Medicare when they turn 65. So they will be eligible. These are our tier 2 people. They will all be eligible for Medicare.
Cassandra, even though they haven't paid in on Medicare because they're paying that 1.45, that makes them eligible?
Yes, the HIT taxes, yes.
Well, that's interesting. Now, what percentage of our members are on Medicare, and then we're providing the supplement for them?
I'll have to get back to you. I'll do a little calculating while we're working, doing another part of the presentation, and let you know. But we do have quite a few members that are tier 1 that paid into Social Security. Now, we can't totally rely on our records because we only have what the individual did with the county. We don't know other employment that they had or whether they'll be eligible through a spouse. We don't have any of that information, so we can only rely on what we have here.
I got you. I appreciate it. Thank you.
Mr. Moore?
I just want to know if I can have a copy of the presentation.
Absolutely.
Okay, and not this one, but the prior one also.
Okay. We'll be sure to get that to you.
Okay, thanks.
Wayne, the
Yeah.
prior one got to scare the heck out of us. It was amazing.
I know. I wanted some of those charts.
I'm not
Me
sure. I'm
too.
not sure I want that.
Steve, I think you can continue.
Can I? Because I think you guys effectively peeled back the onion and went, this is why this is so hard. So yeah, let's go to the next slide. There we go. All right, so each part of Medicare has different rules and eligibility and enrollment. And again, just as we pointed out how confusing and difficult this is, the terms eligibility and entitlement are often used interchangeably, but they have different meanings under Medicare rules. So eligibility means that someone is eligible for Medicare, but is not yet kind of enrolled or is covered by it. So someone could, to Cassandra's point, met the 10 years of 40 quarter requirements, so they're eligible, but they may continue working. Entitlement means that someone is both eligible and enrolled in Medicare, and that's an important distinction. So for example, a qualified beneficiary's COBRA period can be cut short if he or she becomes eligible or entitled to Medicare. That's just kind of one way of kind of how that closes. So why don't we go to the next slide? And again, I think this gives us a real good sense of kind of the history and involvement of health insurance and health coverage over time. So again, we talked about what is covered in Medicare, but probably more importantly is what is not. And I think this not slide is kind of more aligned with
That's-
what people's expectations are today. Trustee Oakham? Or Trustee Moore, I can see.
Yeah, just quick, if you have a member that's 65 and is eligible for Medicare, but the spouse is now 62 and not eligible, does he have to stay on our retirement program for her to have insurance? Or if he goes on Medicare, will the spouse continue to have our insurance?
So you're breaking up, but I think that was a great question. I think that really goes to the point Cassandra made earlier, which is each case is specific. So for instance, they may be eligible for LACERA's retiree program. What their horrible term, but let's say trailing spouse would be, do I take COBRA with the former employer's plan, or am I eligible to enroll under LACERA? So again, those circumstances could be very different and very difficult to give advice kind of across the board universally.
Okay, thanks, Steve.
Sure. Cassandra, you can nod if I'm right.
Yes, that's correct. But also for our program, Mr. Oakham, keep in mind, we do have corresponding plans for those individuals that may be we call a split family, such as what you're asking about.
Thank you.
All right. So again, the slide we're looking at now is kind of all the things that Medicare typically does not cover. What we've seen is with the advent of the Part C plans or those Medicare Advantage plans, is that many of these previously non-covered or non-traditional benefits have been kind of wrapped up into these new plan offerings. And so they become just another reason why they're attractive to members to migrate from traditional Medicare into kind of these Part C plans. So we'll go to the next page. It's time for the first quiz.
Yes. Can you go back one, please? Thank you. To the quiz. One more. There we are. So here's our first quiz based off of information Steve just provided us. What does Medicare Part B, as in boy, cover?
Covers, you want hospital services, outpatient services.
Not quite. You're one ahead of yourself. Part A is your hospital services. So in this case, it would be your outpatient services because you're going to see the doctor. And that's your Part B, as in boy. Very
Right.
good. So we have 57% that answered that correctly.
I like this thing where you give us the answer before we have to close our voting.
Oh, I'm sorry. I didn't realize you guys were still voting. Okay.
It's no, keep it up. It's great. I'm doing much better.
It's a nearly open book, and Trustee Oakham can have one more cup of coffee.
Do you recall how Steve said that Medicare is funded?
Federally. Oh, sorry.
This one you can make two choices.
Oh. Okay.
Okay. Voting time up. Okay. You may recall Steve saying that Part B is funded through federal taxes, which is FICA, and then beneficiary premiums, which is the Part B cost that they're paying. So those are your two choices that were correct. And then Part D, when was Part D enacted? If you think about us, when we first started talking about participation in the retiree drug subsidy program, for those of you who were on the board, do you recall when that was? A little hint. Voting up. That was in 2003. Very good. Great. Next slide, Laura. One thing while we're changing the slides, just so you know, our Part B premium currently is $148.50. We're still waiting for them to announce what the Part B final cost will be for 2022. It's projected to be a $10 increase. which may or may not be the case, but as soon as we hear what the final Part B is for 2022, we'll be sure to let your board, the trustees, know.
I have a real quick question that
Yes.
many people ask. If we're telling members that after 25 years, the county covers your medical costs, and this was hard to explain. But then they have Medicare and, you know, they're required to sign up for Medicare at 65. Then why do they have to pay anything if the county promised, you know, those promised benefits? If they promise to take care of us health-wise, why are they having to worry about paying something?
Good question. Good question. The Part B premium is provided through a federal program, which is Social Security, as we stated, that is not a county-sponsored or county-administered program. So when they started the program back in the 70s, who would have known the cost would have been as it is now? And because our benefits are so great, the thought was you wouldn't need anything different. But here we are today in 2021, and things are very different than what they were back in the 70s. And even now within the healthcare industry itself, you have options of a Medicare plan versus a non-Medicare plan. And in order to enroll in those Medicare plans, you need to have both parts A and B. Hence, we encourage the members to enroll in Part A and B in order to take advantage of the various plans that are being made available to them, whether it be Medicare or non-Medicare for our Tier 1 people.
Yeah, but Cassandra, let me see if I get, if they sign up for A and B,
Mr. Oakham.
148.50, is that correct?
You're coming in and out again.
Wait, am I getting ahead of us?
No, you're coming in and out. I couldn't
I'm
hear your
sorry.
question.
Can you hear me now?
Yes.
Okay, my question is, you paid the 148.50, the basic cost of A and B, is that correct?
We
And
will,
also-
yeah, we
and
will
also-
reimburse for those people that are enrolled in one of our Medicare Advantage or our Medicare Supplement plans. We will reimburse them the standard Part B amount that they pay to Social Security.
So therefore, Vivian, they are not going to have a cost. And I think with Medicare, they're going to have better insurance, I think, than we have with our plans. Is that correct, Cassandra?
It will coordinate, so depending on what plan they have, there would be no out-of-pocket cost for them.
Right. The only thing that happens, Vivian, is if they make more money than, and I've forgotten the basics, but if they're making a lot of money, then there's an extra cost of the 148.50 that we don't reimburse. Is that correct, Cassandra, as I understand it?
Correct. Those high-income people that are being means tested, they will have to pay more than the 148.50, but the standard amount is the maximum amount that the county approves for reimbursement.
Then Vivian, which is not good for us, but you tell them if they're making $200,000 a year, they're going to have an extra cost with Medicare. So they stay with our regular programs and they don't go with Medicare, so they won't have a cost. Correct, Cassandra?
That is a lot of what we're seeing with the Tier 1 people, yes.
Yeah, okay, thank you.
Yeah, because bear in mind, that's not possible under Tier 2. Under Tier 2, they have to go into Medicare. And I think it's important we understand there is a difference between Tier 1 and Tier 2 in who is in which tier. So don't make that mistake of giving people who are new hires advice exactly the same as you give the advice to people who are retired, because it may be a totally different answer.
What's
Absolutely.
Tier 1? What's Tier 2?
Okay. Tier 1 is what we call our legacy people. Those are people like ourselves that worked for the county prior to 2014. Effective June 30th, 2014 and after, everybody that is hired by the county June 30th and after are now Tier 2 people. Tier 2 people, it's a mandate because we know they pay HIT tax. They will be eligible for Medicare, and hence they will have to enroll into a Medicare plan.
Okay, thank you.
Vivian, you had the right answer. If you're not sure, call Cassandra.
And they've only got member coverage, no dependent coverage.
Absolutely.
in
Oh,
tier two.
God.
Absolutely. I don't want to confuse them. We can get into that a little bit later when we get to, because I have some other numbers for you that deals with tier 2 people.
Hey, when I retired from the city, I had to go to my health benefits training twice to get somewhat of an understanding of what was going on.
Yeah, yeah.
And I wonder why it took all day.
Wayne, did you learn it?
You know, I got what was important to me and my own situation, because all you can really do is so complicated that, you know, you got to know what your position is, whether you're qualified or not qualified, and then what kind of plans your employer offers. And you got to see what fits into you, and you got to worry about your spouse. So it's a lot of different pieces that you got to put together to get a plan that works for you.
Yeah. Ms.
And
Gray,
that's what retirees are going to have to do. They got to sit down, because you can't listen to somebody tell you. You have to understand what your place is and what your position is.
Ms. Gray, that's what I was saying yesterday about it's not a one shoe fits all. Sometimes member will tell us what their personal health situations are, and sometimes they won't. We can only go off of whatever they tell us and try to guide them based off of the information they give us. And
Okay.
so our thing yesterday with the whole AI and them being able to sit and take time for themselves would work perfectly for something like this, because they could spend time looking at the stuff themselves, taking into consideration what their personal situation may be.
Okay, that's what I'll tell everybody. Each person is different. Call
Yep.
Cassandra.
For retiree healthcare.
Yes. Nope. Okay.
Steve?
We've had a good opportunity here to look at this slide, so I don't think I'll belabor it. But again, Part A is for the hospital side or component of Medicare. So inpatient stays, skilled nursing facilities, hospice, and home healthcare services are covered. Again, the note there that long-term care is not covered under Medicare Part A, and that's sometimes a confusing point for someone who's going from skilled nursing facility and then is going to require long-term or custodial care. Medicare does not pay for that, so that's typically why you have to have other solutions to deal with long-term care. So we go to the next slide.
Steven, can I ask one question here? And I've had clients call me. CalPERS, just for your information, is raising their long-care cost
Long-term care.
by, excuse me, guys, by close to 50%. Have we had that issue with the plans that people have purchased through LACERA?
Knock on wood, we have not. We've been very fortunate with the plans that we have been in sponsorship with. Our members have not had large increases such as we've seen and heard of through CalPERS long-term care program.
Well, I think what I'm seeing, I did some research on this. CalPERS is funding, they've got an administrator, but they're funding this program. Therefore, they're losing money, so they had to raise that 50%. I just couldn't believe it. I couldn't believe it.
Yeah.
So you want sure we never handle that. We go to another firm that sells long-term care.
Yeah, we don't have anything to do with the policy itself other than making it available to our members.
Yeah, great. Thank you.
And they also got sued by their own members. They lost a multi-billion-dollar judgment. They are currently doling that money out to their members who had their premiums go up, 5 to 10-fold. So long-term care at CalPERS is a mega mess. And fortunately at LACERA, we don't have not had, and will never have those problems because we do a whole lot better job.
You got it. I saw that. I couldn't believe it, Les.
Okay, thanks for integrating that into the presentation, because that's an important item.
Steve, we needed to give you a little help, Steve.
I'll take all the help I can get today. On this slide, again, just kind of a recap of what I think our discussion has taken us to, which is, again, in order to receive kind of Medicare Part A eligibility at no cost, you need to work 10 years or 40 quarters. And as Cassandra noted, that could come from a variety of employment over your career. Individuals under age 65 with a disability would be eligible for free Medicare Part A. And then again, those with end-stage renal disease who've paid in for 10 years and are kind of receiving services for that would also be eligible. But I think if we go to the next slide, I think this probably would touch on one of the points that Vivian brought up, which is, Part A, is it free? Okay, so when it's free, that's one thing, but I can buy in. But this is, I think, where a lot of retirees will kind of look at this and say, is it worth it to me? And this particular point has a lot of kind of cascading impacts to LACERA and some of the other things we're working on jointly with staff and in management is, if it's not free, I can buy in. So if I've been working, say, between 30 and 39 quarters, I could buy Part A, but that would be at $259 a month in 2021. Obviously, that will increase over time. But if I'm below that threshold, then the cost to purchase Medicare Part A would be $471. And so again, you can see that dramatic shift in cost for someone that's going, okay, it's supposed to be free. Well, you weren't eligible. And as we've touched on, the tier 1 retirees or individuals in the tier 1 may not have eligibility for Medicare at zero cost. And so is it worthwhile for them to make that additional purchase? There are plans within LACERA that provide coverage for those retirees that are not Medicare eligible. But if we're talking, Kaiser is a good example. There are plans that can cover them and provide decent coverage. When we get to the Anthem side of the house, which is Plan 1, Plan 2, and the Prudent Buyer Plan, those are plans that I can enroll in without Medicare, but they have the $1 million lifetime maximum. And so, while we have discussions about trying to negotiate or increase the lifetime maximum for those plans to put them on par with your other retirement plans, put them on par with kind of the county employee plans, there's a cost to this. And so Cassandra alluded to it before, which was if I'm means tested and I have to pay a higher premium, either because I didn't work a quarter or I'm going to pay a higher amount, there is some risk there in terms of short-term savings, but being in a plan that has a limited lifetime maximum. So again, that kind of cuts both ways. So that's why this is such an important issue. Trustee Gray, you have a question?
Yes, I do. We're talking about these 30 and these quarters that they should have worked in order to be eligible and determine how much they would have to pay. The working quarters are outside of the County of Los Angeles or within working for the County of Los Angeles?
It can be both.
Oh, okay.
Yeah.
All right.
Any kind of way they meet the 10-year mark would qualify them for the 40 quarters.
Okay. All right. Because I know what's confusing is that, and Mr. Oka might have an answer. What is confusing is that in order to be eligible for Social Security benefits, you have to have worked 40 quarters, not 39. That's separate and apart from the medical coverage through Medicare, which is administered through Social Security, right?
It would be basically the same 40 quarters because they count them both, whether it's 40 or 10 years paying into Social Security will qualify you for Social Security, but then you're also eligible for Medicare as well. So it's a combination of both.
Okay.
Just doing a time check. Does anyone need a break? Because we're right at that, just about at that break part. If you need a break or anything, or we can keep going.
Cassandra, I think if it's okay, we can keep going and then, take a break after this.
Perfect. Okay. Steve?
All right, let's go to the next slide. So we touched on the fact that, again, Medicare was designed back in, 1966, 65, so 56 years ago. And so its design is based on that time period, not what people are accustomed to now. So when you talk about what does Medicare Part A cover, you've got someone that's coming out of retirement, coming out of active service and moves into a plan, and maybe they had maybe they're in the Kaiser plans. They're used to a $10 copay. They're used to 100% coverage for hospitalization, unlimited days. The Medicare program is far different. So there's a deductible that needs to be met for each episode of care or benefit period. And then there's coinsurance that's applied. So for the first 60 days, there's kind of zero out of pocket for the member. But if an extended stay should occur, somewhere between 61 and 90 days, the coinsurance would go up to $371 per day. So as you look at that, that can really escalate. And that's why there's a lot of attractiveness or benefits to Medicare supplemental plans, which try to wrap around this design and minimize the members out of pocket. And again, at LACERA, you've got the supplemental plan through Anthem. So you can see that there's a great deal of financial risk to a member for large out-of-pocket expense without some sort of a wrap or Medicare Advantage plan. Want to go to the next slide? Okay. Part B coverage, again, we touched on this a little bit earlier, but just a quick recap. This is primarily for outpatient services, physician visits, lab tests, durable medical equipment, ambulance services, etc. So we can go to the next slide. And then again, the cost sharing. So we've kind of alluded to this before. The county has a program to reimburse the standard Medicare Part B premium, which at this point in time is $148.50 and will increase next year. But as was referenced already today, it's means tested. So members with the highest level of incomes might have to pay $505 per month for Medicare Part B. And the county only reimburses the $148.50, the standard amount. So there is some discussion is it worthwhile for me to pay into that program to get that? And so, people have to kind of make those decisions on their own. But again, there's a large risk. And I think if you're been successful over your career and you're at the highest level of the means test, you've probably been very successful. Yes.
Hey, Steve, be sure to tell them what that 148.50 is based on with respect to the amount of their modified adjusted gross income, because every single deputy sheriff on the LA County Sheriff's Department, regardless, just the deputy exceeds that $88,000 a year.
So there's the table scales up to your point. As starting point is 88.5 and scales up from there. And again, the top threshold I think is
500,000 and above.
Yep. So,
right.
So again, again, Vivian, I think you brought it up, is that each case is specific. And so that's why it's so difficult and so important to have, quality counselors that can work with retirees as they're trying to determine what to do and how to go forward.
Steve, also,
yes.
Also, if you're in that position, you got to pay it twice with the wife. So, if the wife has Medicare, she's got to pay the $148.5 too, $148. We don't reimburse for that. Is that, Cassandra? We only reimburse for the member.
For tier 1 people, we will reimburse this for the spouse as well. As tier 2, we only reimburse the member.
Okay, and also, if the members' fees go up to whatever, $300, $400, $500, the wife's will also go up. So now you're looking at, after 25 years, it's a much better deal to stay just with LACERA's health costs because it won't cost you any money, and the other one costs you a lot of money.
Yeah, I know we have one case where the member was not eligible for Medicare, actually reached his lifetime maximum. And he found it very beneficial to go enroll in Part A and B for both he and his wife. So he's paying in excess of $1,000 a month for his Medicare. Steve?
Thank you.
In the essence of time, why don't we go to the next slide? So again, just a quick summary. Part C, again, these are the Medicare Advantage style plans. So again, it's providing coverage comparable to what's available under traditional A and B. But again, it's probably more of an updated look from a participant's perspective. If I'm, again, an active employee in the county and I'm using Kaiser, I can migrate to LACERA and I can enroll in the Kaiser Senior Advantage plan. And it looks and feels exactly what I've had before. So it's a very nice transition. There's typically added benefits added to that. We talked about dental coverage, vision, hearing. So there are a lot of different things that can be added to that mix that kind of make them even more attractive.
Yeah. And just go ahead.
I'm sorry.
Go ahead, Sean.
Yeah. So if you enter into the Medicare Advantage plan, you have to be in a Medicare Part B plan. Is that correct?
So good question. I was getting ready to say for our LACERA plans, we have the Kaiser Senior Advantage, we have the United Healthcare Medicare Advantage, we have SCAN, and then we have Cigna Health Spring, which is in Maricopa County in Arizona. In order to enroll in any of those plans, as well as our Medicare supplement, they have to have both Part A and Part B in order to be eligible to enroll in any of those plans.
Perfect. Thank you.
Why don't we go to the next slide? Okay, so again, as we talked about, members, Cassandra, I think just covered this slide beautifully. Thank you. Got to have both parts A and B, and again, those combinations typically will cover the overall premium. So let's go to the next.
Fun time, back to the quiz.
Yes,
fun
please.
time, fun time. Okay, so here we are. Part A, what benefit does Part A cover? We need that. Da, 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 da. Voting up. Part A covers hospital services. Very good. Okay, so Part C is provided on a fee-for-service basis, through an HMO, through a PPO, or none of the above. And I guess I'll let you do 2 answers this time.
I'll give you that discretion. 2 answers would be good. They might be in the middle.
Pretty good, pretty good. This one actually would have been voting up, I hope, would have been B, the HMO and PPO plans. And our last poll this time, Part A covers expenses on the basis of a calendar year, a plan year, benefit period, or a 6-month period. Voting up. Answers, please. Close, not this time. Remember when we started out, Steve had said that it's paid on a benefit period. It's by benefit. It's based on when someone is goes into the hospital, and that's called a benefit period.
So again, I think that really points out such a hard transition to work with Medicare, regardless of traditional or Medicare Advantage. In today's world, because they just don't line. What you've learned is completely different from what it will be going forward unless you align with one of those Medicare Advantage plans. Why don't we move forward then to Medicare Part D, which is just a quick summary on the prescription drugs. There we go. All right. So again, I think Cassandra had touched on this based on the earlier exchange with Trustee Oakham. So prescription drug plans. So they need to either meet a standard benefit as determined by CMS, or they can have something that's equal to or better than that. So again, because most of prescription drug plans are administered by pharmacy benefit managers, there can be vast differences between what drugs are covered and not on a particular formulary. So again, for those purchasing on an individual basis, I think as Trustee Oakham referenced, you almost need to do a line-by-line assessment of what prescription medications are you on and which of multiple prescription drug plans offer those drugs, so minimizing your disruption and providing you the best cost option. So on an individual basis, that's typically how it would work. But with respect to LACERA, we've got drug programs established by that are in place with CVS that are associated with the Anthem plan. And then we have prescription drug formularies that are directly aligned with United Healthcare or SCAN. So there's not a lot that the member needs to do to kind of work through that. But again, during this kind of open enrollment cycle for Medicare, members will receive just an onslaught of solicitations and requests for conversations, things like that. So again, this is such a difficult time of the year for retirees. When we go to the next slide. So I think we kind of touched on some of this, so I'm going to go ahead and move to the next slide. Great, thank you. So on this one, again, we're kind of providing some parameters around what the standard plan design parameters are. So again, very different from when Part D plans were introduced to kind of what they look like now. Biggest difference is we had always had an annual maximum deductible. So in 2021 dollars, it's 445. And then the initial period, benefit period, is when the plan and the beneficiary contribute costs or pay costs upwards of 4,130. And then we get to the quote unquote donut hole, which in its original incarnation really put a lot of that liability on individuals. And since the introduction of the Affordable Care Act, that donut hole is really closed to the point where now beneficiaries are paying, about 25% of the drug and the plan pays 75%. And for generic medications, and then we have a catastrophic coverage option too, where the beneficiary is still responsible for 5%. And then the Medicare pays 80%, and that's kind of how that kind of works itself out. But again, this is under traditional Medicare Part D, and far different than the plans that are associated with your Medicare Advantage plans, where again, more traditional copay arrangements, generic formulary brand, and out of pockets at that point. So we'll go to the next slide.
Under our LACERA group, our members did not have the donut hole, so they never had to experience that. Although sometimes when they went to the pharmacy, they may have had to pay a reduced cost for their prescriptions, but they didn't have to adhere to the donut hole. They didn't have that.
And at the introduction of the Part D programs, in order to encourage plan sponsors like LACERA to continue providing services and benefits to their members, they introduced a retiree drug subsidy program. And that in essence provides the plan sponsor about 28% subsidy returned from the federal government to kind of offset the cost of doing that program. The other option is an employer group waiver plan, which is traditionally aligned with plans that self-insure their pharmacy program and typically run on a calendar year basis. And a couple of things that LACERA doesn't do. So LACERA has periodically looked at that option, but has felt that the retiree drug subsidy program works more closely aligns with your objectives and goals and still provides a great deal of value. So I'm going to let LACERA, Cassandra, talk about some of the benefits that you've reaped from the RDS program.
Yes, so we've been participating in the RDS, or the Retiree Drug Subsidy Program, since 2005, 2006, when it first came available. Since that time, we've received in excess of 163 million in retiree drug subsidy for the plan sponsor. We, as Steve alluded, we did check into or look into changing over and doing the egg whip or the employer group waiver plan. However, there were just many hurdles that we would have had to go through, such as changing our entire program to a calendar year versus a fiscal year and all of that, which would have required the county's approval to do so. So we were getting just as much for the retiree drug subsidy program, so we stuck with that.
So why don't we go to the next slide?
Poll time. So our first question, all Medicare Part D plans must cover the same prescription drugs, true or false? Voting up. Very good. False. They all have different formularies. Here we are with the donut hole. Donut hole is required for Medicare beneficiaries to pay 100% of all incurred outpatient prescription drug expenses, 5% of discounted prescription outpatient drug expenses, 25% of incurred outpatient prescription drug expenses, or 25% of incurred inpatient and outpatient drugs. Voting up. Very good. It was C. So that one tied A and B, but A and C, but it's actually C, 25% of the outpatient prescription expenses. And our last question on this poll, each Medicare prescription each Part D prescription drug plan must use the same cost threshold each year as prescribed by CMS, the standard benefit, true or false? Voting up. Wrong. It's false. That's a false one. We got you on that one. No, they are not all required to have the same threshold.
Are you grading on the curve?
No,
I hope
just
so.
it's just as fun.
We considered detention with me, but that's not going to go anywhere.
No.
All right.
Okay.
I think we're heading into the home stretch here. Just a couple items that I think we've previously addressed, but we'll give you some reference point to the exhibits. So we'll go to the next section. All right, Medicare enrollment.
Yeah.
Perfect. Thank you. All right, so again, I think we've demonstrated Medicare is not easy, and neither is enrollment. So members have a window to enroll once they've met the 4 quarters. We've touched on this one, so why don't we go ahead to the next exhibit? There we go. So the initial enrollment period. So this is when you're initially eligible to enroll. And again, it's usually a 7-month window that straddles your 65th or 67th birthday or wherever that may occur. And so that's kind of how that one works. So it's again, I think to me, the biggest issue or kind of where this kind of runs afoul for LACERA members is those that have retired early. Let's say safety personnel. So they've retired, but they've been part of the LACERA program for upwards of, could be 15, 20 years. Okay. And now they become eligible for Medicare. Well, this transition, it's like, okay, I didn't know I was supposed to change, or I didn't know I was supposed to do this because they've been on autopilot for 1 or 2 decades. And so this is where it's, again, important for us to continue to educate and make the retiree healthcare staff available to council members so they can sign up when they should and avoid penalties.
And what we usually do is 3 months before their 65th birthday, we will send them out notification letting them know that if they are eligible for Medicare, there are other plans that would be available to them, and for them to contact Social Security to find out whether or not they are actually entitled to Medicare or not.
I'll go to the next slide. All right. So I will readily admit that I still find all this confusing. Okay, so you get your initial enrollment period, and now you'll see the general enrollment period, which runs January 1st through March 31st. And this pertains to people who did not sign up during their initial enrollment period. So that means they're going to incur a Part B premium penalty and a potential penalty for premium Part A as well. So again, if we can help people avoid this window, that would be great. More commonly, though, is the annual enrollment period, which is exactly where we're right in the middle of. So we'll run from October 15th through December 7th, and members have the ability to kind of change Part C plans, Medicare Advantage plans. They can return to traditional Medicare. So a lot of options here. And again, this is probably the biggest or most heavily promoted time period for Medicare eligibility. And then the next one on the next slide.
Here's where we tell members not to do anything to check with us first.
Yep. And then the last one is the Medicare Advantage open enrollment. Again, kind of an odd one, but runs January 1st through March 31st. Allows members to return to change plan Cs, which again is not direct. This is kind of outside of LACERA. So thank you, Cassandra. But members can go from a Part C plan to another Part C plan or to traditional Medicare. But they can't switch from traditional Medicare to a Part C plan during this window. So again, clear as mud, right? All right, let's go to the next slide. And here's a snapshot of the late penalties. So the Part A premium penalty is a one-time penalty. If you're late on Part B, it's a penalty that's payable for life. So again, that can escalate for someone who is not enrolled in Part B on a timely basis. The shorter duration, more you can get them back on track is great. And then there's also a penalty for Part D for those that enroll more than 63 days after having coverage. So again, typically that may not be an issue for a LACERA member because their pharmacy program is going to be combined with their medical plan.
Hey, Steve, a question about the 10% penalty.
Mhm.
Is that 10% penalty based on what number? What their actual Part B premium means tested is, or the lowest number Part B premium out there? I've had retirees tell me both.
I may go out to my lifeline because I know that our compliance team is on the call, but my understanding is it would be applied to whatever their means tested premium would be.
So it could continue to go up, fluctuate too.
And it could be significantly higher than kind of what the standard level is. And then applying that 10% premium to that higher number is another reason why some members are hesitant to take the step to enroll in Medicare. Want to go to the next page? All right. There are some special enrollment periods alluded to for individuals or their working spouse. The special enrollment period lasts 8 months from when an individual's employment ends and the month after group health insurance coverage ends for them. So it's just one more period that I think Cassandra and her team have to kind of work with and make sure members are kind of navigating kind of this process properly. Want to go to the next page?
Steve, do you need a letter or some from an employer indicating that you had insurance until you retired or it stopped?
That would probably be a good suggestion, just to make sure you have something to validate when coverage ends. I believe that employers, because the Affordable Care Act, are going to have to send out materials regardless of when your employment ends.
Yeah, I know we also provide letters of notable credible coverage for our members.
Thank you.
Exactly. And Social Security requires that special enrollment form and validates the group health plan coverage.
Right.
So I am going to suggest going right to the quiz on this one because we've kind of culled through a lot of this. And I do want to be respectful of time here. It's been a robust discussion.
Okay, here's our first question. When must a person age 65 without health coverage first enroll in Medicare to avoid a late premium penalty? Can we have the poll, please?
1 moment.
During his or her initial enrollment period, during the annual enrollment period, during a special enrollment period, which is a loss of employment based on coverage, during a special enrollment period following the termination of COBRA. Voting up. Let's see the poll. Very good. Everyone looks like just about got it correctly. 83%. So they have to do it their initial enrollment. Otherwise, they'll be considered late and have to pay that 10% penalty. The late penalty for premium Part A is for life. Yes.
Yeah, but what if they're still working and getting insurance coverage from somebody else? They don't have to sign up for Medicare, do they? As long as they're still getting insurance from somebody else.
Great question. Great question.
That's what I was thinking.
Yes. So if someone is still working, if they're eligible for Part A, we encourage them to go ahead and take Part A, but they do not have to take Part B because they would have to be paying for it. They wouldn't use it. The employer group is primary. So there's really no reason for them to take Part B while they're working. But if they're
that was a trick question.
Yeah.
Okay, so I'm working and I have a Medicare card. I just threw it in the box, in my jewelry box. I don't need it, right?
Nope. Not what I mean. The only time your employee or your plan now would use it is if you were hospitalized. They may recoup some funds that they use in servicing you. But other
Oh.
than that, you don't need it.
Okay, all right.
Good question. So our next question, the late penalty for premium part A is lifetime, life of the Medicare beneficiary, true or false? This is for part A.
Part A or part B?
This is part A.
This is double jeopardy. So there's big dollars going on here.
Poll, please, the response. It actually is false. Very good. Okay, and the 7-month enrollment period is for the special enrollment, general enrollment, annual enrollment, or the initial enrollment period. Poll close, please. Very good. Initial enrollment is the correct answer. Yay. So you guys are remembering some of this, huh? I'm going to ask you again at the next week at the board meeting.
Can you just do this again at the board meeting?
It'll be
Actually,
every board meeting, 3 questions. Boom, boom, boom.
Hey, did we get, will this stay with us? I think it'd be a good idea to have these charts.
Yes, we can certainly give you the handout.
Charts would be helpful to review every once in a while.
Yeah, if they could just stay in our board vantage, so we don't have to kill a tree. And I don't have to search for wherever I put it. Board vantage is really good.
We'll make sure that it's placed in there.
Oh, Bonnie said she'll put it in the education file.
Yeah.
And also Dr. Arisman's presentation. That's perfect.
Great.
All right, we're going to the lightning round here. I will do 2 slides as quickly as I've ever done 2 slides. So next page. All right, Medicare secondary payer law. So Medicare will pay secondary to another group policy health plan or insurance policy. So again, they're just trying to save federal dollars. So if there's an entity that can go first, they'll allow them to do that. And how do they validate that? Let's go to the next slide. Don't make me go backwards. That's cruel. All right, secondary payer law. So again, they'll work with insurance companies to identify when they should have been primary and when they should have been secondary, and they'll work through the insurer to kind of recoup funds that are due to them. So whether working with Anthem or Kaiser or another program. So that's the essence of trying to save money for the Medicare program over time by making sure they're not expending dollars they shouldn't. And that's all I have for that one. I think it's time for our last question.
That's related to A, is that correct? That's the only thing related to part A.
No, it could be, I believe, either, right?
Correct.
Yeah. We do sometimes receive those notices from CMS saying that they believe that they've overpaid. And we have a old opinion provided to us when CMS used to be HCFA that we send out to them with the information of that member that they're asking about, verifying that they're in a retiree only plan. And then we'll soon after that get something saying that the issue's been resolved and the case is closed. Because as a retiree only plan, Medicare is primary for our group. Except for in certain situations such as the end stage renal and all of that, then it may play primary, but that's for a very short period.
Well, that's what's confusing to me because Medicare is primary with us, but yet I'm sitting here reading about Medicare secondary payer, and this confuses me.
That's what they call the group that tries to collect money when they believe that they've paid incorrectly. If we were the county, say for example, then Medicare would be secondary and the employer group is primary. But because we're a retiree only plan servicing retirees, ours is secondary. Our plan is secondary. Medicare is primary.
Right.
Okay, our poll. Medicare pays second when a beneficiary is covered under a group plan due to COBRA, group plan due to their current employment, retiree group health, or group health plan before receiving 30 months of Medicare coverage. And this one, I'll let you choose two.
It won't let us choose two.
Oh, why
My
is that?
apologies. I set this one up as a.
Oh,
single
okay,
choice.
that's okay. It's okay. Okay, so
What's the favorite
let's
choice?
see the first one. Let's see the one choice. And then I'll give you the answer for the second one.
Oh, I want a round robin for the second one.
Poll, please. That is correct. Any guesses as to what the second one would have been?
COBRA continuation coverage.
Nope. It would be,
Uh,
oh, go ahead, Ms.
and-
Gray.
End stage, if they have the ERSD end stage renal.
Very
disease.
good. Very good. That would be D as in dog.
I think you won
What
the
is
entire presentation.
Mr. Holcomb? What'd you say, Mr. Holcomb?
What's ESRD?
End stage renal disease.
Okay, thank you. I didn't know.
Yeah. So prior to just this past year on when members enrolled in our Medicare Advantage plan, there was a question that was on that form asking whether or not someone had end-stage renal disease. They've rethought that, and because of that, we've had to redo our forms to remove that question off because that is HIPAA information that they were asking clearly on the form. So now our forms no longer ask that question. Let's see, we can do, here's, I'm gonna do you another little quiz. So we have Mrs. Flintstone, who is a retiree. Her spouse, she's 65, her spouse is 71. They both currently have Medicare A and B. Do you remember the plans that we offer as LACERA, a LACERA group to these members that we have with Medicare? We have the Medicare Sup, which is, what's our Medicare supplement plan?
Senior Advantage or Medicare?
Anthem Blue Cross 3.
Oh.
Yeah, so HMO plans are the Kaiser, the United Health, Scan, Cigna. All of those are considered HMO plans. And all of those are the Medicare Advantage plans. Those plans require the individual who has A and B to assign their Medicare to them. Versus our Medicare supplement, Anthem Blue Cross, they do not have to assign their Medicare. They can use their Medicare wherever they want to go. The HMO plans tend to have preferred providers and their primary care providers at their facilities or a facility contracted with the plan. So that's the difference that we see members selecting. Depending on, we see a lot of people who may have Anthem when they're working, and they think that when they retire, it's going to be the same plan. It's not the case. That's not the case. And that's what we have been telling members now. Even though the name is the same, make sure you review the benefits because the benefits are different than what you had when you were working. But again, that only goes with as much as they share with us. We try to direct them. But we had a case not long ago where we did tell the member that there's different plans and this is the plan you need to look at, but we can't tell them what benefits we think that would work for them because we don't know. We do have cases where there's split families, which I mentioned before. We call split families where one member is eligible for Medicare and the other one is not eligible for Medicare. Under our LACERA group, we do offer corresponding plans. So for example, if a member has Medicare and they enroll in Anthem Blue Cross 3, their spouse then has an option under 65 of plan 1 or 2. where the member can participate in 3, but the spouse or the children would be under Plan 1 or 2. Normally, when I'm counseling or I talk to a member, I usually let them know, I don't tell them to even look at Plan 1. I just take them directly to Plan 2. And that's because that one has that $2,500 out-of-pocket max per calendar year versus our other Anthem plans, wanted in the prudent buyer plan, there is no maximum out of pocket. So they're going to continue to pay regardless as to whether for whatever amount they incur for that plan year, they're going to continue to pay until the next year, and then it starts all over again. Whereas our Plan 2 has an out of pocket max of $2,500. And
Hey.
so they have a stop loss there.
Cassandra.
Yes.
Cassandra, what about Kaiser?
Wait, let me hear Mr. Oakham real quick. Mr. Oakham?
Yeah, the question I had is that the number 2, does that have the $1 million cap also?
Unfortunately, all of our Anthem plans, with the exception of Anthem Blue Cross 3, does have the lifetime maximum.
All right, let me ask this question. I'll make sure I'm understanding. Somebody's on Medicare, employee on Medicare. They can go to Medicare and the spouse, we will still pay for the spouse in that plan 2. Is that correct?
Yes, if the member enrolls in Plan 3 and they have a spouse who's not Medicare eligible or don't have Medicare, they can enroll their spouse into Plan 2, and those 2 plans coordinate. So the member can be in 3 and the dependents can be in 2.
Oh, perfect. Thank you.
Mr. Santos, I think that was you that was Herman Santos.
I'm sure he was going to ask about Kaiser. If he is eligible for the senior Kaiser, but his wife is not, what happens there?
Under our Kaiser plan, we do have rate deduction or rate categories, which addresses that, where the member in this case could have Medicare if the spouse doesn't, or vice versa. The one could enroll in Senior Advantage, and then there's another category for the spouse or dependents or the member who doesn't have Medicare to also be in Kaiser. So the member can then enroll in Kaiser, but they'll have different benefits.
Wait a minute, you said the member, okay, so Santos or Herman can enroll in Medicare Senior Advantage.
Correct.
But his wife, who is that little young thing, she can't get Senior Advantage, but we have a way of getting her into
We have
Kaiser?
a category with a split family situation such as that.
Okay.
So he could still enroll in Kaiser and his wife not be in Senior Advantage, but he would.
Okay, and she would be in some other Kaiser
She would be in
plan.
what we call the traditional or the basic Kaiser plan, whereas he would be in Senior Advantage.
Well, who pays for her?
Because he's tier 1, the county will subsidize it.
Okay.
Remember, it's only tier 2 people that the county will not subsidize for dependents.
Okay, so Herman is okay.
Yes.
Thank you, LA County.
Any other questions you wished for us to address for you since we are on this topic? I pride myself in trying to learn as much as I can about Medicare because I know it's very difficult for members to try to get through to Social Security sometimes. Sometimes even when I try to outreach someone at Social Security, I have a difficult time. And then it depends on who you get at Social Security, whether or not the representative understands your question or if they even care enough to give you the right answer. It's a hit and miss.
Can we possibly, and I think I've brought this up before, and I know budgeting is very hard on retiree healthcare. But would it be advantageous to have a liaison between Social Security and retiree healthcare, or even between member benefits because of the WEP? Well, I guess that's a question I would have to ask Luis and Santos, but it seems like we need some sort of liaison, a member services or a retiree healthcare person to be that liaison with all the knowledge of Social Security and the interaction between Social Security and LACERA on both the retiree healthcare and retiree benefits, member benefits. So I don't know. It's a
Trustee
thought.
Gray, no, that's a great thought. And I think that's something in terms of working through our opportunities with Cassandra. I know Social Security does have various public affairs officers that do this type of outreach and partnership, similar to our partnership with Empower. You know, in terms of the ever-changing, you know, laws of Medicare and obviously the Social Security enrollment rules. So that's something to explore. And I know Steve and Siegel, you know, keep abreast of all those changes as well. But I think that's something to factor in because Medicare is such an important aspect of our retirees' decisions when they look at their complete healthcare coverage. So something for us to consider and think about.
JJ?
For quite some time, we did have a relationship with one of the local Social Security offices, and they would at times participate in some of our outreach events and our internal webinars. I believe they have pulled back on that cooperation. They don't do that anymore. But I agree, it's something, if it's possible, because we used to do something like that in the past, it would be wonderful to see if that type of relationship could be restored. In the meantime, you know, from my point of view is I firmly believe that we need to develop the internal knowledge base so that we can answer those questions, and that all member services, call center and outreach and member service center staff and retiree healthcare staff should be trained on that so that they are the experts and can answer those questions. They're all trained on the web. I know Cassandra's team is obviously trained on the Medicare and the Social Security issues, but we need to make sure that's consistent so that we can have that collaborative approach that we talked about yesterday, and so that everybody can answer that same level of question if necessary. Thank you.
With that, Cassandra, Steve, any other closing remarks?
There was one bit of information that I did want to share. I took the liberty of querying our system to see for our tier 1, our tier 2 people, how many people that we had that have either retired or survivor that are enrolled in the retiree healthcare program. We have a grand total of 6 people enrolled in our healthcare program. 3 of them are 65 or older, and 3 of them are under 65. Of course, the 3 that are 65 and over have Medicare and are enrolled in our Medicare Advantage plan, one of our Medicare Advantage plans. And of the 3 that are under 65, 1 is in a PPO plan and the other 2 are in the HMO plan. So just thought that was a little bit of interesting information, since we know that there's light at the end of the tunnel with regards to Medicare and getting our members enrolled in Medicare. But where are we today? And so right now under tier 1, we have 6 people enrolled in the retiree healthcare program.
I think just to add to that perspective is, as we talk about the lifetime maximum for those 3 Anthem plans, that's an important point to note, is that we're just beginning that migration of people from tier 1 to tier 2, where tier 2 will be the bulk of it. So as we're trying to talk about the cost impact of increasing that lifetime maximum, it is a finite population that will decline over time. So just something to keep in mind.
Great. Thank you, Steve, and thank you, Cassandra. Very comprehensive presentation. Certainly the slides are very good in terms of providing some foundational knowledge. I think overarching is the overall theme that Steve and Cassandra alluded to is no 2 employees are alike. Not at once, you know, it's not a one size fits all. So in that essence, it's important to have, to JJ's point, all of our team members skilled and understanding not only Medicare and the enrollment, but also the retiree healthcare and how it impacts some of the health plans that we have and how it impacts certain employees. I think about even our group here, our trustees, you all have different work histories, life histories, and that all plays a role and impact in terms of what your retiree healthcare landscape will look into retirement. So with that, we'll break and then we'll come back to our final presentation. So 15-minute break and we'll be back 11:13. Okay, welcome back, everyone. Just want to make sure okay. So we get to close out the morning with a healthcare legislative and regulatory update from Siegel Representative Kathy Bakic. Did I get that right? Senior Vice President of National Health Compliance Practice, and Amy Dunn, Vice President, Senior Consultant, Health Compliance. Kathy and Amy, thank you for joining us this morning.
Good morning. Thank you for having us.
Great. Well, I'll allow
morning.
both of you to kick it off.
Hi, everybody. This is Kathy Bakic. I've been out with you in person several times. I'm sorry I can't make it in person this time, but hopefully we can get a good session on Zoom, and you should ask any questions that you feel that are important at any time, and we'd be happy to talk about them. Amy is my colleague on the West Coast. She is in Southern California and is hopefully going to be working with you as well. So I'm going to take the first part of the session, and she's going to take the second part. So if you want to move to the next slide, we're going to talk a little bit about the new administration. And, we know the new administration, but one of the things that I like to talk about with the new administration is who's running the behind the scenes story. So everybody knows the president and vice president. Let's talk about the cabinet and who's on the cabinet and what we can expect to see from them. For the labor secretary, we have a former union president, Marty Walsh, who is the mayor of Boston, president of laborers locals in Boston, and is going to focus on workers' rights and has a big challenge in overseeing the OSHA and some of the changes that OSHA is making in wage and hour. In addition, there's the Employee Benefits Security Administration, which is not directly involved with you, but does set some employee benefits-based policies jointly with HHS and Treasury. We have a new nominee for EBSA, Employee Benefits Security Administration Deputy, or I guess she's the Assistant Secretary, Lisa Gomez, who is a good friend of mine, and she works out of New York for a labor law firm in New York, but has been very involved in representing health plans and pension plans. So she's very familiar with how plans really work. So that's a great addition for us in the Department of Labor. I expect her confirmation to be finalized sometime before the end of the year. I don't need to tell you about the Health and Human Services Secretary. I think that we can expect Secretary LACERA to focus on civil rights. So we'll definitely see an emphasis on civil rights, on diversity and equity. And Amy's going to talk about that a little bit more toward the end of the presentation. Treasury, Janet Yellen, I don't think is known as an employee benefits specialist, but what we see in Treasury is that we have a lot of career staff in Treasury, and the folks in Treasury have been working with employee benefit plans for a long time. There really aren't any political people on the employee benefits plan side there. It's really all just career staff. And then the Justice Department, we don't know exactly what we're going to see from the Garland Justice Department. So there may be some involvement of there, particularly maybe in Title VII litigation or something like that, or supporting civil rights litigation, but we'll have to wait and see what comes out of the Justice Department. So that's just a kind of a background on the leaders of those departments and what we might see coming out of them in the next few years. If you move to the next slide. I wanted to just talk a little bit about what we have seen so far. Now, some of this applies to you, some of it doesn't, but it's all about employee benefits policies that you're going to be dealing with in your work. So we had the American Rescue Plan Act back in March. That enacted a COBRA subsidy, which only lasted for 6 months. It's already over. There was a paid sick and family leave tax credit, which is important because we expect to see a new paid leave program that I'm going to talk about a bit later. Expansion of the ACA exchange subsidies and expansion of other tax credits and providing some aid to governments in that act. If you move to the next slide. The paid sick and family leave tax credit was a tax credit that it has expired, but it provided employers with under 500 employees a tax credit for providing leave related to COVID. Now, the reason I think this is important, even though it's expired, is that this sort of laid the groundwork for the federal paid leave program that's part of the Build Back Better Act that I'm going to talk about in a few minutes. You move to the next slide. The Families First and CARES Act were actually in 2020. And what they did was require plans to pay for COVID-19 diagnostic and blood tests, test administration, and the visit related to that test administration. In addition, on the next slide, the act required payment of vaccines, coverage of vaccines as soon as they were approved, and that's part of the preventive benefits that plans have to pay. Now, these two rules don't, for the most part, apply to retiree-only plans, but what I've seen in the retiree-only plan environment and also with the Medicare plans is that this was all picked up and paying for COVID tests and paying for vaccines has been picked up pretty much across the board. One of the interesting things that is not totally across the board is whether plans are paying for COVID treatment at 100% or whether they're paying for it at the regular percentages and as a regular expense. And some plans, particularly some Medicare plans, did pay for COVID treatment at 100% early on, but many of those plans have rolled that back and are just covering it like any other health treatment right now. Move to the next slide, please. The vaccine, I know that you guys have, have talked a lot about vaccines. It's a very big issue in Los Angeles. And we're seeing vaccine mandates throughout the country, really. Most employers that I'm working with and most retiree or most employee benefit plans are talking about what they can do to encourage vaccines. We have a lot of federal guidance on vaccines and it kind of keeps evolving. The first set of guidance we got was from the Equal Employment Opportunity Commission, which is responsible for the Americans with Disabilities Act enforcement. And they've provided a lot of guidance about what employers can and can't do with respect to asking people about vaccines and mandating vaccines. We've also seen guidance from HHS indicating that HIPAA doesn't prevent asking about vaccine status. HIPAA only applies to health plans, but it kind of has become sort of a talking point for anything to do with anything about privacy, but really it doesn't apply to employers and it doesn't affect whether an employer can ask somebody whether they're vaccinated. If you move to the next slide, we've also gotten guidance from the federal government announcing that health plans can provide incentives in the health plan. So if you had, for example, an active population, you could charge person a higher premium if they're not vaccinated. You could also provide for some benefits in the plan for those who are vaccinated. For example, you can give them a lower deductible or maybe waive cost sharing for certain benefits. We've seen vaccination requirements generally being upheld by the courts, and we've seen them being implemented by large employers across the country. Delta Airlines was one of the first ones to announce a health plan penalty, but they're certainly not going to be the last. We're expecting more guidance about vaccines because the president is going to be issuing guidance under OSHA for private employers as well. And we have the federal contractor guidance that requires vaccination by, I think by December 8th for all federal contractors. So lots of movement in this area. And it does appear that the vaccine, certain studies have shown that, mandating vaccine does increase the vaccination rate in the country. So if you want to move to the next slide, another COVID related item, the government has said that health plans can cover things related to COVID, such as paying for personal protective equipment. So masks and sanitization, stuff like that can be paid for out of a HRA or an FSA. Next slide. Taking a little bit of a different topic, telemedicine. It's kind of related to COVID-19, but also, many plans have used telemedicine as a benefit prior to COVID. Both telemedicine is available both through a company like a Teladoc or another company that's actually requires you to sign up and register and then just use their doctors. And that's really kind of more for urgent care kind of situations. Or a lot of plans have put in provisions that allow an individual's treating physician to provide coverage via telemedicine. The federal government has waived a lot of security rules about how those interfaces have to be conducted to allow healthcare providers to conduct those telemedicine visits more easily. I've read a recent statistic that 3 out of 4 employers in their employee benefit plans either reduced or waived cost sharing for using telemedicine in the last year. Now, there is some legislation pending in the federal government, it's the Telehealth Expansion Act, that would further reduce barriers for using telemedicine. It would provide more consistency across state law and allow more extensive use of telemedicine. It would also allow telemedicine benefits to be paid before the deductible for high deductible health plans. So that legislation is not currently moving in Congress, but it may come up after we get through some of the things that are going on now in Congress. Go to the next slide. Just a few things on the Affordable Care Act. I'm sure you all know that the Texas versus California lawsuit was decided by the Supreme Court, where they threw out the third challenge to the Affordable Care Act. The Biden administration has indicated that they wanted to expand the ACA. And if you go to the next slide, we have seen some expansion of the ACA. The American Rescue Plan Act expanded subsidies within the Affordable Care Act. So these are for people who don't have employment-based coverage, and they can go onto the exchanges and purchase healthcare coverage and receive subsidies up to 400% of, for people with up to 400% of the federal poverty level. Now that expansion in the ARPA Act was only for 2 years. So in the Build Back Better Act, one of the things is to expand those subsidies on a permanent basis. And I'll talk about that in a second. Move to the next slide. The ACA exchange enrollment has increased pretty dramatically, and partly as a result of those enhanced subsidies. In addition, the administration allowed another open enrollment window to allow people to come into the exchanges. Some states had already expanded their enrollment processes. Some states hadn't, so the federal government had a general open enrollment window for everybody. And as you can see in 2021, we've had the highest enrollment in the ACA exchanges, almost 30 million people enrolled in those exchanges. You move to the next slide. So that's kind of what's happened. Now I'm going to talk about what might happen in the future. I guess we would take a break. If anybody has any questions about what I've already talked about, we can talk about that. And now I'm going to talk about Congress. So what's happening on the Hill, there's 2 bills that are moving on the Hill. One is the bipartisan infrastructure bill, and the other is budget reconciliation legislation. The Senate has passed the bipartisan infrastructure bill. The House was expected to vote on both that bill and the budget reconciliation bill by the end of September. That deadline passed. The new date for the vote on both of those bills is the end of this week, basically October 31st. It's really unclear whether that vote is going to happen because some of the bill language isn't even finalized yet. We saw, like in the last day or so, we've seen a couple of brand new tax proposals coming, out of the blue, sort of, to be included in the bill. Those tax proposals haven't been, finalized or scored by the Congressional Budget Office. One is a billionaire tax, and what is a corporate minimum tax. So this thing is still really being put together, and it's kind of unclear what we're going to see. But I'd like to tell you about what's in the infrastructure bill for sure, and then we might see in the Build Back Better Act. So in the infrastructure bill, this is a bill that provides for roads and bridges and electric car charging places and things like that. And that bill is done. It's written. It's been passed by the Senate. So in the next slide, there are only a couple things in there that apply to plans. One is that there will be a new provision that would allow HHS to kind of track refundable single dose containers and basically not lose money on single dose dosages that are not ever used. The next slide is probably a more important provision, and that's related to the Medicare rebates. Now, there's a bit of a long history here, and so if I don't say it right, I'm going to ask Steve maybe to talk about the implications for your plan. But the in the last few years, the Trump administration published some regulations that would eliminate Medicare Part D drug rebates and require any discounts from manufacturers to be available to individuals at the point of sale. Now, this was a really controversial bill because it would have cost the federal government about $177 billion over 10 years. There was litigation over that rule, and it resulted in the regulation being put on hold by the Biden administration. What they said was, well, we're not going to implement that regulation ending Part D rebates. We're not going to do that right now. We're going to wait and study it for a year. But then in the infrastructure bill, there's a provision that says that the HHS secretary may not implement the Medicare Part D drug rebate change until at least 2026. So they can't implement it before 2026. We don't know whether it would actually ever be implemented after that. So Steve, do you want to talk about what this might mean?
Yeah, thank you, Kathy. So we brought this up during our kind of routine meetings to go over the experience report, and we do try to highlight the rebates associated with the pharmaceutical drug program through CVS. And I think it's important to note that I think while the intent is to create more transparency in the healthcare system, and drug rebates is clearly an area where it's maybe counterintuitive to kind of what it's accomplishing. Regardless, you are getting value for those rebates. So if the program were to change or the rules were to change, would LACERA get equal value in discounted costs, or would you kind of come out short on the other side where you may not be made whole? So it's just something to keep in mind as these progress, that there is value currently for LACERA. And if the rules were to change, how would that impact your overall budget? So that's just something we'll always keep in the forefront. So thanks, Kathy.
Thank you. So if you want to move to the next slide, that's pretty much all that's in the infrastructure bill. And and that bill's not going to change. That bill's going to pass as is. Then we get to the Build Back Better Act, which is the budget reconciliation bill. And I'm sure you've heard about the political background behind this. The Democrats have 50 votes in the Senate. So they've been trying to get an agreement with all 50 Democratic senators. And the White House has started to become more and more active in this effort. It's done as a budget reconciliation bill because of our partisan, issues right now, and the fact that they can only get it passed with 50 Democratic senator votes. Now, the limits with the reconciliation bill are that there are certain things that can be passed as a reconciliation that affect budgets or taxation. And then there's other things that can't be passed if they're not related to the budget or tax issues. Just to give you an example, I was working with a client on part of the paid leave bill, and we mentioned the word ERISA in there to define a term. That's it. And they're like, oh no, that's not going to pass the reconciliation test because ERISA's got the jurisdiction of the Labor Committee, not the Finance Committee. And so if we put the word ERISA in there, they're going to kill the whole thing. So So we had to figure out another definition for the terms. That's the kind of nitty gritty stuff that they're dealing with. So the reconciliation bill is intended to be the big bill that will pass things like expanded leave, more affordable childcare, enhanced household tax credits, lowering the Medicare eligibility age, although that didn't make it in probably because of that reconciliation problem that I mentioned, and expanding Medicare benefits to include dental, vision, and hearing. The tax changes are being watched. As I mentioned earlier, we're seeing tax proposals coming out now, and the bill is supposed to be passed at the end of the week. So either those tax things are not going to be in there, or the bill's not going to pass at the end of the week. So if you want to move to the next slide, talking about some of the things in the bill, probably one of the most controversial items in the bill is the Elijah Cummings Lower Drug Costs Now Act, which has previously been passed by the House and is now in the Build Back Better Act. This is the bill that would allow Medicare to negotiate drug prices with manufacturers. The bill allows that negotiation and does cap the negotiated prices at a price based on an international pricing index for other OECD countries. Those Medicare negotiations, I think, would begin in 2024. So that's a key part of the bill, but it's also very, very and under intensive lobbying by a lot of parties. In addition, under the bill, there would be a mandatory rebate by drug manufacturers for certain B or D drugs, with prices increasing faster than inflation. Right now, that bill would also allow commercial plans and employer plans and plans like yours to also take advantage of that rebate for certain Medicare Part B and D drugs where the prices are increasing really fast. And then finally, the Medicare Part D benefit would be significantly modified to eliminate the catastrophic cap over which participants pay cost sharing. They would eliminate that cap, so there would be no cap for the participant to get benefits, and it would change who pays during that cap. The payment would be 30% by the manufacturer, 50% by the plan, and then 20% from Medicare. And Steve, I don't know if you'd want to comment on any of these provisions as well.
You're too kind, but no.
Okay.
Has to pass first.
Has to pass. Yeah, it's really, they thought that this was going to pass pretty clearly a few weeks ago, but then when it went through committees, there were 3 Democrats in the House that voted against it. It doesn't clearly have the support of all the Democrats in the Senate. So it's unclear what's going to happen with this drug legislation. You move to the next slide. The Build Back Better Act also would make those ACA premium tax credits permanent. They would be so that'd be a more generous benefit for people that go into the exchanges, and the ACA exchanges, and buy coverage. In addition, it would change some of the employer shared responsibility testing rules. And it also, for very low income people with income below 138% of the federal poverty level, which is probably around $13,000, it would allow them to get into the exchanges even if they have access to employer coverage. Move to the next slide. The Build Back Better Act also contains a paid leave program. And so remember, I talked about paid leave under the CARES Act earlier. This would be a permanent paid leave program. And it's really a massive program. Right now, it's at 12 weeks, but I think it's going to be cut down to 4 weeks of paid leave. And it creates a new federal family and medical leave benefits program that provides paid leave when somebody goes off for family or medical related issues. If the employer already provides paid leave, then the employer can get a subsidy of up to 90% of their costs. And the program will be tagged at about 2/3 wage replacement. So it's broader than the Family Medical Leave Act. The FMLA leave is unpaid. This would be paid leave. The only problem is that it creates another program that's administered by the federal government and it does not preempt any of the state programs. So, for example, the California paid leave programs would still be in place. This would be an additional program. And there is some subsidy money to support state programs like California's. So this is a huge program. It's a big deal. I think it's going to stay in the bill, but it's going to be cut down to 4 weeks instead of 12. That's the latest I've heard. The next slide. This is just more detail about that paid leave program. Go to the next slide. Public option. What about the public option? It's not in the bill. So at this point, I don't think we're going to see any more about that, at least for the time being. Next slide. Drug importation. The federal government has had the right to import, to permit importing drugs for a long time, but it's always required the HHS secretary to attest that the importation of the drug is safe and secure and will not harm Americans. No HHS secretary has been willing to do that attestation. Under the previous administration, there was a regulation that allowed state governments to submit proposals to the federal government to import drugs, including insulin and certain other drugs from Canada. Now, there's a few states that have submitted proposals. I know Florida has sent a proposal in. I'm not sure what other states have sent proposals in, but they haven't been acted on yet by the current administration. So we really, on importation, we're really in a waiting period. We know that there's some activity, but we don't know what the Biden administration's position is going to be on this. So this is something we're waiting and seeing on. So with that, I think the next slide, I'm going to turn it over to Amy.
Thank you. Thanks so much for this great information, Kathy. Yes, let's continue on into this executive order. Because hearing aids are so expensive, only about 14% of the 48 million Americans experiencing hearing loss use hearing aids. So on average, they cost about $5,000 per year. And these costs typically aren't covered by insurance plans. And so the higher prices and typically are driven by the need for patients to see a doctor or specialists for a medical evaluation, which several experts believe is really unnecessary, and it's unnecessary barriers to competition. So the Biden administration has directed the Department of Health and Human Services to consider issuing proposed rules within 120 days, and that's actually coming up, I believe, next week, to allow hearing aids to be sold over the counter. And so that's going to be a really interesting development. So stay tuned, actually, more for that. We'll go to the next slide. Hospital transparency. Hospital price transparency it really its intention is to help Americans know the cost of the hospital item before a service before receiving it. And so starting this year, each hospital operating in the United States is required to post a clear, accessible pricing information online about their items and services that they provide. And they're required to do this in two ways. Through what's known as a machine readable file, which is a digital representation of data or information in a file that can be imported or read into a computer system, and that contains certain standard charges for items or services provided by the hospital, including gross charges, discounted cash prices, payer-specific negotiated charges, and de-identified minimum and maximum negotiated charges. It's also required to display at least 300 shoppable services, or as many as the hospital provides, if it's less than 300, that the healthcare consumer can schedule in advance. And so it must contain plain language descriptions of those services. And this information, its intention is to make it easier for consumers to shop and compare prices across hospitals and estimate the cost of care before going to the hospital. So how's this going so far? Well, compliance so far by hospitals has been low. CMS has actually recently come out and said that they're looking to strengthen their efforts to increase price transparency. and holding hospitals accountable for ensuring the consumers have the information they need to make fully informed decisions about their health care. And so CMS has actually proposed to increase penalties for some hospitals who are not complying with these rules. And so again, that could be anywhere, again, from their proposals, not final, but proposing anywhere from $100,000 if it was for a full year, depending on the size of the hospital, all the way potentially over $2 million a year. So again, why is this important all to know? Well, in the coming years, we're actually planning on seeing this within health plans, so that even at the health plan level, individuals will have the ability to see and to understand how much services would cost in advance to receiving those services. So again, more to come there. We go to the next slide. As Kathy talked about earlier, we wanted to focus a little bit more on looking at some of the principles regarding diversity, equity, and inclusion within health policy. And so President Biden has passed Executive Order of 13985 on his first day in office to show that there was a commitment in advancing equity, civil rights, and racial justice. And equity opportunity is the responsibility of the government. The administration defined the term equity to mean the consistent and systematic, fair, just, and impartial treatment of all individuals, including individuals who belong to underserved communities that have been denied such treatment. Among other things, the executive order encourages federal agencies to conduct equity assessments on their policies to ensure that the underserved communities aren't encountering significant barriers and accessing opportunities made available by their policies. So the administration also plans to allocate federal funding to underserved communities who are systematically haven't been invested in and identify opportunities to promote equity in the budget, and the president will submit ultimately to Congress. So we go to the next slide. A large focus of the administration's policies were to eliminate, again, the barriers for the marginalized communities, increase equity in employment options and such. And so the Executive Order 14035 intended to advance DEI in the federal government's recruiting, hiring, development, and retainment processes. And so because the federal government is the nation's largest employer, the executive order promoted a belief that the workforce should reflect diversity in the American people. And so this executive order also ensures that LGBTQ employees, including the beneficiaries and dependents of all those employees, have equitable access to healthcare and to health insurance coverage. Additionally, the Secretary of Defense also should take actions to promote equitable healthcare coverage and services for LGBTQ members of the uniformed services, including beneficiaries and eligible dependents, including coverage for comprehensive gender-affirming care, again, through the military health system. So we go also to the next slide, talking a little bit more now about some United States Supreme Court decision last year, as well as the Affordable Care Act, Section 1557. So just to give you a little background here, the United States Supreme Court ruled in June of 2020 the federal protections against workplace sex discrimination under Title VII of the Civil Rights Act of 1964 extend to discrimination based on gender identity and sexual orientation. And this was actually a 6-3 decision in a case called Bostock versus Clayton County, Georgia. Again, back in June of 2020. And again, Title VII prohibits discrimination on the basis of race, color, religion, sex, national origin in the hiring and firing or compensation of benefits and other terms and conditions of employment. The law generally applies to the public and private employers with 15 or more employees. And in light of this decision, we've seen a great deal of plan sponsors that they've been looking at their plan documentation and administration, determined to make sure that their terms of their plans, make sure they don't discriminate, again, based on the terms of sexual orientation or gender identity. And if we now move to the next slide, Section 1557, the Affordable Care Act, prohibits group health plans from discriminating again on the basis of race, color, national origin, sex, age, disability, and health programs consistent with existing federal laws. Well, also in June of 2020, Department of Health and Human Services revised significant portions of the original rules, removing protections against discrimination on gender identity or sex stereotyping. And so again, the new final rules made a few additional changes, and chief among them removed the requirement for covered entities to distribute non-discrimination notices and tagline translation notices in at least 15 different languages in significant communications, and also a non-discrimination statement in shorter publications. Department of Health and Human Services noted that this was extremely costly. It duplicated many other non-discrimination notices and those requirements for covered entities. And so consequently, for any communications after August 18th of 2020, the plan sponsors were not required to provide this level of detail in these discrimination type of notices. Additionally, though, the rule still requires language assistant programs and accommodations for those with a disability, and also website accommodations. So we can also go to the next slide to go into this year. In May of this year, the Department of Health and Human Services issued a press release and a notice indicating that its intent to interpret and enforce the ACA Section 1557 to prohibit discrimination on the basis of sexual orientation and gender identity. This announcement was made in light of the Supreme Court case back from June of 2020, along with other subsequent lower court decisions interpreting federal civil rights laws and providing those protections. And so on its own, this announcement did not amend existing rules under the previous administration, but it's the next step in the process that we'll see future rulemaking here to come. And if we go into the next slide, one of my favorite topics has been around actually for quite some time: HIPAA security, HIPAA privacy, that we're very aware of, which came around back in 2003 and also in 2005. We're very used to seeing protecting, making sure you're protecting PHI, seeing privacy notices, but we've also seen a fair amount of activity when it comes to enforcement, because there have been since that period of time a great deal of breaches, specifically when it comes to the security of electronic protected health information, or EPHI. And so earlier this year, there was a federal law that was enacted. Again, it applies to the covered entities, which includes health plans. It also includes healthcare providers that are subject to the HIPAA security rule. And it's really looking to provide a level of recognized security practices in those enforcement activities, and following guidelines and best practices from the National Institute or Standards of Technology, also known as NIST. And so again, I think it is just a matter of looking at the consistency of what type of technology is protecting this kind of information. And again, as time evolves, as technology evolves, there is still going to be constant looking at this to how to protect this information, especially when there are breaches. There have been a fair amount of hacking type of incidents and again, making sure that the covered entity is doing its best to protect this level of information. I believe that was the intent of this rule here. And so finally, into our last slide, this brings it to it as kind of a key takeaways. I think as both Stephen and Kathy have talked about, that the agency enforcement of these federal health laws, again, continue regardless of the administration. We're definitely seeing more activity as far as transparency goes, price regulations, federally subsidized benefits, that again may impact your group health plans. Privacy and security is just talked about. Again, it's been around for some time, and I definitely think it is still here to stay. And again, we see in the principles throughout and coming through into the benefit programs too, of diversity, equity, and inclusion will definitely become more prevalent over time. And so with that, I'm happy to open it up to any questions, or Kathy or Stephen, any kind of other comments as well.
Amy, thanks. A quick question with regard to privacy and security. as members call in and kind of describe issues they're facing or trying to get resolution with a carrier, can you quickly provide us like some context on what is protected health information or what needs to be secured based on those conversations?
Yeah, definitely. It is so again, part of this is also going to depend on the type of arrangement and who exactly is the covered entity in a fully insured type of situation. It depends also who is getting that kind of information. And so again, if member services, if individuals are calling up, sharing that level of information, they have access to that information. Again, in that case, it is going to be important to make sure that that information is protected. For example, not only just in the conversation that we may be having, but also are things recorded and maintained within a computer system? Is PHI then turning into, if you will, ePHI? Both of those rules could come in depending on those type of circumstances. So again, if it is part of the administration and part of having those having that information, it is okay. But then the rules come in to have that information and making sure that that information is being protected as well.
Okay, and just a quick follow-up. What kind of training would member services team members need to get annually or periodically with respect to managing that protected health information?
Yeah, that's a great question. I would definitely, I personally like to see it done annually. I also think that it's important if someone, for example, is new to an organization, but they're dealing with protected health information, maybe as part of their role, they would want to be trained as soon as practical for those cases. But on an ongoing basis, I like annual because it just keeps it fresh, and a lot of things change. Technology changes. For example, we just gave a little update as to a good thing to know, and always be keeping that top of mind of what to do, where to go if there are questions, and how to keep that information protected.
Thank you.
Mr. Robbins has a question.
Yeah, I don't know if either Amy or Kathy could address this or not, but about a week ago, I saw an article that Congressman Larson out of Connecticut was going to introduce a bill changing how Social Security computes its annual cost of living, and also had some language in there eliminating the WEP. I'm curious if either of you know anything about either of these. Not exactly healthcare, but since you have your finger on the pulse back there, I thought maybe one of you might know something about what he's up to.
I don't know anything about that particular proposal. One of the things that's stymieing some of the Build Back Better Act is the fact that Senator Manchin has said he thinks we need to focus on entitlement reform. That's their term. Looking at programs and making sure that Medicare or Social Security remain solvent. So I don't think those kind of proposals are going to go into this bill, but that's kind of an always, there's always a group of people working on those kind of proposals. We can take a look at it and get back to you with more information about the details.
Yeah, thanks. I just figured if you guys didn't know an immediate answer, I'd lateral this ball over to Steve and let him address it at a future committee meeting. Thanks, but thank you very much.
Thank you.
Okay, well, thank you, Kathy. Thank you, Amy and Steve, for the presentation, and really thank everyone this morning for your presentations. This concludes our board offsite. I'm gonna pass it to Santos for some closing remarks.
Thank you, Louis. I just wanted to thank all of the presenters today. A lot of really good information was shared. Excellent questions all around. With that, I want to thank my staff and my management team for putting on what I think it was a very, very good virtual offsite. It's the first one that we've had. We appreciate all of the support of the trustees, and we're hopeful that this will be a good springboard for us moving forward through the strategic planning process and making sure that our retiree healthcare program continues to be number one. in the state and in the country, quite frankly. So with that, I'll turn it back over to Chair Bernstein for some final comments.
Thank you, Santos. Before I close, I don't, it's been a long and informative day and a half. I don't want to go through an entire good of the order, but is there anyone who'd like to make a comment? Any trustees? I'm happy to yield the floor for a moment if anyone wishes to say something. And if not, I will close this out. Santos and everybody, thank you. I also, before I say that, I want to thank the trustees. You gave up a day and a half to be here and to learn. I appreciate the commitment of my colleagues to being here and to participating and learning, but it was staff that drove this and put it together. Mr. Robbins, I think I see it. You're interrupting, but no, please. You're on mute. Les, you're on mute.
I'm now unmuted. I didn't want to cut you off, Alan. I just wanted to throw something in that, and all the context I get from retirees, they either have an issue with something that's going on and they need some clarification, or they're about ready to retire and they want to know which health insurance plan is best for them, or they're about to turn 65 and what the heck do I do about Medicare? And what we've talked about today is pretty darn enlightening, but these are obviously huge decisions that active employees have to make as they transition from active service into retired service. So, and it's complicated, it's real complicated, and one size does not fit all, as we have been made aware of even more clearly today. So just a quick thank you to everybody that participated and took part. Was very, very informative and important information. I'll shut up.
Thank you for adding that. Vivian?
I just want to say thank you to staff. I know when we were putting together the agenda, I kept sending lists of things I wanted you to cover. And I have to say that staff covered everything. I absolutely loved day one. It gave me the feeling that we are really looking out for our members and making things better for them. I mean, these are the people we serve. And I just really liked day one. Day two, the Medicare, all my questions were answered. Now I know that to tell everybody to call Cassandra, it's really simple. And if Kathy Magida is on the line, I'm gonna give them her number too. She thinks she can get away with it because she's retired. Not. And of course, Les Robbins, I'm gonna send them his way because he's the expert also. But it is truly amazing what staff did to put together all of this. I truly appreciate it. It was a great learning session for me, or re-education session, something we need to do often. So thank you.
Thank you very much, Vivian. Anyone else? I think they've said it all. I think in addition to all the content, Santos, what really came through to us is the bench of talent that we have here at LACERA, the experience, the wisdom, the insight, the professionalism. And it was great to have so much of that highlighted throughout the day and a half. So I really appreciate that. I believe we all really appreciate that. And thank you for leading that and organizing it. And it's been great. So thank you again to everyone who is here. And I would be happy to entertain a motion for adjournment. I think I'm going to give Les credit for a muted so moved.
So moved.
Without objection, thank you, Wayne. Without objection, we are adjourned.
All right.
Have a good day, everyone.
Good job, everyone. Take care.
Great presentations.
Thanks, Wayne.